Welcome to Nightshift Horror. Before we check in tonight, don't forget to like, subscribe, and let me know where you're tuning in from. Now get comfortable. The night shift is about to begin. The fluorescent lights in Gross Anatomy Lab B14 hummed with that particular frequency that gets under your skin after the third consecutive hour. I remember thinking that as I leaned over the stainless steel dissection table, scalpel poised above the thoracic cavity of our assigned cadaver, a 73-year-old male, cause of death listed as myocardial infarction. It was my second semester at Jefferson Medical College, and the rhythm of dissection had become almost meditative. Remove the skin, identify the fascia, separate the muscle groups, document everything in precise anatomical terminology. The methodical nature of it appealed to the part of me that had always found comfort in procedure. In the predictable progression from unknown to known, my lab partner, Rebecca Mills, had gone to grab fresh gloves from the supply station near the entrance. The silence that followed her departure wasn't unusual. The lab maintained an almost cathedral-like quiet most evenings, broken only by the occasional murmur of consultation between students or the soft scrape of instruments against tissue. That's when I noticed it, movement in my peripheral vision, caught in the reflection of the polished steel table surface. Just a flutter, like someone had shifted position behind me. I glanced up instinctively, expecting to see Rebecca returning, but the space behind me remained empty. The other tables stretched in orderly rows, each occupied by focused students bent over their work. I returned my attention to the dissection, but the sensation persisted, that awareness of being observed that prickles along your spine. This time, when I looked toward the steel surface, I focused deliberately on my reflection. The overhead lights created a reasonably clear image in the polished metal, distorted but recognizable. That's when I saw myself blink, except I hadn't blinked. My reflection had closed its eyes a fraction of a second before I did, like a delayed echo running in reverse. I stared harder, leaning closer to the table surface. My reflection leaned closer too, but again, there was that subtle disconnect, a half-beat delay that shouldn't exist. Exhaustion, I whispered to myself, the word barely audible in the quiet lab. Microsleep episodes, perfectly normal after 18 hours of studying, but as I straightened up, my reflection smiled. I hadn't smiled. The expression on the face in the steel was unmistakably mine. The slight upturn of lips that my mother always said made me look like I was keeping a secret. But my own face remained neutral, even as I watched the reflected version maintain that knowing smile for several long seconds before finally matching my actual expression. My hands began to shake. Not the fine tremor of caffeine withdrawal, but the deep, bone-level shake that comes from a fundamental disruption of what you understand to be possible. I set down the scalpel and stepped back from the table. "Rebecca?" I called out, my voice carrying farther than intended in the empty lab. No response. The supply station stood empty, though I could have sworn she'd only been gone for a minute or two. I checked my watch, 8:47 p.m., the same time it had been when she left. Either my watch had stopped, or time itself had become unreliable. I approached the table again, this time from a different angle, watching my reflection materialize gradually in the curved edge of the steel surface. Normal behavior, normal timing. My movements and their reflections synchronized perfectly, until I turned to leave. In the steel, my reflection turned to face me directly, even as my actual body moved toward the exit. For one impossible moment, I was looking at myself looking back at me, two perspectives that couldn't coexist in any rational understanding of physics or optics. The reflection mouthed something, words I couldn't hear but somehow understood. "Don't leave yet. We're not finished." I grabbed my backpack and headed for the door, not caring about protocol or proper cleanup procedures. Behind me, I could hear the soft scrape of instruments against steel, the gentle sounds of someone continuing the dissection work. But the lab was empty. I was certain of that. The next morning, I returned to find our cadaver's thoracic cavity completely dissected and documented. Every muscle group labeled in meticulous handwriting that looked remarkably like my own, though I remembered stopping work before making significant progress. Rebecca asked who had finished the assignment. I told her I didn't know. Since then, I've started wearing gloves constantly, not just in the lab, but at home. in bed, even in the shower. Latex, nitrile, vinyl, it doesn't matter. Something about the barrier between my skin and the world feels necessary now, protective. Because sometimes when I catch my reflection in windows or mirrors, I see it move independently for just a moment. And sometimes, when I remove the gloves before sleep, I find small marks on my palms, careful incisions that match the dissection patterns we've been practicing. The strange thing is, they never hurt. They're just there, precise and deliberate, like someone with medical training has been using my hands for practice while I wasn't paying attention. I've started sleeping, with the gloves on too. The work we do in that lab changes you in ways the textbooks don't mention. We learn to see the human body as a collection of systems and structures, to separate the mechanical from the metaphysical. But what if that separation isn't as clean as we pretend? What if consciousness leaves traces in tissue, imprints that persist beyond clinical death? I think about that sometimes, when I catch my reflection practicing procedures I haven't learned yet. The anatomy review session was scheduled for 11 p.m. in the Advanced Learning Center, one of those sterile, windowless rooms designed to maximize focus and minimize distraction. Dr. Harrison's holographic lectures were legendary among second-year medical students, not just for their comprehensiveness, but for their uncanny ability to anticipate exactly which concepts would appear on upcoming examinations. I'd been struggling with the cardiovascular system module, specifically the intricate pathways of coronary circulation. My study group had disbanded around 9 p.m., everyone else satisfied with their preparation level. But I knew I needed the extra reinforcement that only Dr. Harrison's methodical explanations could provide. The Advanced Learning Center after hours felt different than during regular class sessions. The motion sensors activated banks of LED panels as I entered, creating pools of clinical white light that followed my movement through the space. 47 empty chairs faced the projection stage where Dr. Harrison's hologram would materialize. I chose a seat in the third row, close enough to see fine details in the anatomical models but far enough back to avoid the slight visual distortion that sometimes occurred in the front rows. The holographic projection system was cutting-edge technology. Dr. Harrison had been dead for 6 years, but his lectures continued with such fidelity that new students often didn't realize they were learning from a digital reconstruction. At exactly 11:03 p.m., the familiar shimmer of light coalesced into Dr. Harrison's image. He appeared as always, slightly rumpled lab coat, wire-rimmed glasses, that particular way of holding his left hand against his chest when making important points. The illusion was perfect, down to the coffee stain on his coat pocket that had been there during the recording sessions. "Good evening," the hologram began, his voice carrying that subtle electronic undertone that marked it as reconstructed audio. "Tonight we'll be reviewing coronary circulation, patterns and their clinical, implications." I opened my notebook and began transcribing key points as Dr. Harrison launched into his explanation of the right coronary artery's anatomical variations. Everything proceeded normally for the first 23 minutes. The hologram moved through its programmed presentation sequence, highlighting anatomical structures on the three-dimensional heart model that rotated slowly in the projection space. Then it stopped. Not a natural pause for emphasis, but a complete freeze. Dr. Harrison's image locked mid-gesture, his mouth open as if about to pronounce the word interventricular. The heart model continued rotating, but the lecturer himself had become a statue of light. I waited 30 seconds, then reached for my tablet to report the technical malfunction. Before I could access the system controls, Dr. Harrison's image flickered back to life. "Thank you for that question, Rachel," he said, turning to address a section of empty chairs to my left. There was no Rachel in the room. There was no one in the room except me. The relationship between myocardial oxygen demand and coronary perfusion becomes critical during episodes of emotional stress. The hologram continued, apparently responding to an inaudible inquiry. "Your particular case history suggests heightened sensitivity to academic pressure." My hands went cold. The hologram was looking directly at me now, though it had addressed someone named Rachel. More disturbing was the content. Dr. Harrison had never discussed individual case histories during his cardiovascular lectures. "I see concern in your expression," the digital Dr. Harrison said. his image slightly more detailed than I remembered, as if the projection system was somehow enhancing its resolution in real time. Perhaps we should discuss your upcoming rotations. This was impossible. The holographic lectures were pre-recorded, static presentations that couldn't deviate from their programmed content. Yet Dr. Harrison was speaking about rotations, information that couldn't have been included in recordings made 6 years ago. Your internal medicine rotation will present challenges, he continued, consulting what appeared to be notes that materialized in his translucent hands. Dr. Morrison will question your diagnostic reasoning on Tuesday, March 15th. You'll second-guess yourself and miss the obvious. Presentation of acute coronary syndrome in the 67-year-old patient admitted Tuesday evening, March 15th was 8 months away. Dr. Morrison was the attending physician for internal medicine rotations. But I hadn't even applied for that rotation yet. The patient will survive, Dr. Harrison added almost conversationally. Your confidence, however, will not recover completely. This will influence your specialty choice. You'll avoid cardiology despite your aptitude. I stood up, chair scraping against the floor with a sound that should have triggered the motion sensors. The lighting remained constant, as if the room's systems had stopped responding to my presence. Your residency match will be in family practice, the hologram continued, apparently unconcerned by my movement. Good match. You'll establish a small practice in Vermont, marry a pharmacist named David Chen, have 2 children. The specificity was terrifying, not because it was impossible, but because it felt inevitable, like reading a medical chart that had already been written. Death will occur at age 53, Dr. Harrison said with the same clinical detachment he'd always used when discussing pathophysiology. Myocardial infarction, ironically. The anterior descending artery will occlude completely during your daughter's high school graduation ceremony. You'll experience chest pain, but attribute it to anxiety. Classic presentation, classic misinterpretation. I backed toward the exit, but the doors had sealed, not locked, but sealed, as if the room had become airtight. The hologram turned to follow my movement, its eyes tracking me with impossible precision. The date will be June 8th, 2055, he concluded. Time of death, 2:47 p.m. Your daughter will remember that you smiled just before you collapsed. She'll become a cardiologist because of that moment. The projection flickered and resumed its normal presentation. Interventricular septum receives dual blood supply from both the left anterior descending and posterior descending arteries. Dr. Harrison continued seamlessly, as if the previous exchange had never occurred. I found my voice enough to activate the room's emergency communication system. Technical support, I croaked. This is campus security, came the response. What's your location? Advanced Learning Center, room C12. There's a malfunction with the holographic system. Room C12. That room's been closed for maintenance since last Tuesday. Are you sure about your location? I looked around. The room number on the door clearly read C12. The holographic equipment hummed with activity. Dr. Harrison continued his lecture to an audience of empty chairs. I'm in C12. I repeated. I'm showing our system doesn't have any scheduled sessions for that room tonight. Can you exit the space and confirm your location? I tried the doors again. They opened normally. The hallway outside was dark, emergency lighting casting everything in red shadows. According to the directory next to the elevator, room C12 was listed as under renovation, no access. When I returned the next morning to speak with technical support, they showed me the room assignment logs. No holographic lectures had been scheduled. For the previous evening, Dr. Harrison's cardiovascular review session was recorded as having occurred the previous Thursday in room A8, but when I checked the course archive system, I found a new entry, late night session, student-specific review. The file was tagged with my student ID number and time-stamped at 11:03 p.m. The audio quality was perfect. Every word of Dr. Harrison's predictions preserved in crystal clarity. At the end of the recording, there was a new addition, a soft voice that sounded remarkably like my own saying, "Thank you, Dr. Harrison. I understand now." I don't remember saying those words. The most disturbing part came when I accessed the alumni database to research something unrelated. My name appeared in a section I'd never noticed before. Projected outcomes, class of 2028. Every detail matched Dr. Harrison's predictions. The specialty change, the location, even David Chen's name and profession. The death date was listed as confirmed Year 6, Year 08, 2055. 2:47 p.m. I've stopped attending holographic lectures. Something about learning from the dead now feels less like education and more like prophecy. But sometimes late at night when I'm studying alone, I hear Dr. Harrison's voice coming from empty classrooms, discussing cases that haven't happened yet with students who may never exist. The future, it seems, is another subject they don't adequately prepare you for in medical school. Every gross anatomy dissection group at Westfield Medical College consists of exactly 4 students assigned to one cadaver. The system is rigid, documented, and tracked through multiple administrative layers to ensure proper allocation of specimens and educational resources. Our group, myself, Kevin Walsh, Amanda Pierce, and Tyler Bowman, had been assigned cadaver number 7, a 68-year-old female who had donated her body to medical education. That was until the morning we found our table occupied by someone else. The new cadaver was male, approximately 45 years old based on external examination, with the well-developed musculature of someone who had maintained an active lifestyle. What made him unusual wasn't his physical condition, it was the complete absence of identification tags, documentation, or any record of his assignment to our table. Dr. Reginald Foster, our anatomy professor, seemed genuinely puzzled when we brought the discrepancy to his attention. "Let me check the procurement records," he said, consulting his tablet with the methodical precision that characterized all his interactions. After several minutes of scrolling and cross-referencing, he looked up with an expression I'd never seen on his typically composed face. "There's no record of this specimen in our system," he admitted. "No donation paperwork, no transport documentation, no preservation records. According to our database, cadaver number 7 should still be the female specimen you were working with last week. Yet here was this new body, properly preserved and positioned on our assigned table, clearly prepared for dissection using our standard protocols. The preservation quality was excellent, better than excellent actually. The tissue had that perfect balance of firmness and flexibility that made anatomical work both precise and efficient. Kevin suggested we report the error and wait for administrative clarification, but Dr. Foster made a decision that surprised us all. "The specimen is here," he said. "It's been properly prepared for educational use. Until we can trace the administrative error, you might as well proceed with your assigned dissection work." What followed was the most productive anatomy session any of us had experienced. The muscular development was textbook perfect, each structure clearly defined and easily identified. The fascial planes separated cleanly, the organ systems were in optimal condition, and every anatomical feature seemed designed for educational demonstration. But there was something else, something none of us discussed directly, though I could see the recognition in my classmates' eyes. The face was familiar in a way that defied explanation. Not familiar like a celebrity or someone from our personal lives, but familiar like looking at a photograph of yourself taken from an angle you'd never seen before. "He looks like he could be related to one of us," Amanda mentioned during our lunch break, voicing what we'd all been thinking. Tyler nodded. "Yeah, but related to which one?" "I keep thinking I recognize him, but I can't place it." 2 weeks passed. Our dissection work progressed through the curriculum requirements: integumentary system, musculoskeletal system, cardiovascular system. Each session revealed new anatomical details with a clarity that made our textbook illustrations seem crude by comparison. We were learning faster and retaining information more effectively than any of our peers. That's when the registrar contacted Dr. Foster. "About body number 12, I need to ask you about the specimen assigned to your afternoon group," Dr. Rebecca Santos said, consulting a clipboard that seemed to have materialized from an era when digital records didn't exist. "There's some confusion about the procurement documentation." Dr. Foster frowned. "We don't have a body number 12. The highest number in our current inventory is number 11. According to our records, someone signed for body number 12 3 weeks ago," Dr. Santos insisted. "The signature is on file, along with all the proper authorization codes." She handed Dr. Foster the clipboard. The signature at the bottom of the form was clearly legible, written in confident block letters that none of us recognized. But the name was unmistakable. It was Kevin's full name, including his middle initial and the precise spelling of his surname. I never signed that, Kevin said, his voice carrying a tremor I'd never heard before. I've never seen that form before in my life. Dr. Santos consulted her records again. The signature is dated 3 weeks ago, the same day body number 12 was delivered to lab station number 4. She looked at our group. That's your assigned station, correct? We confirmed it was, though none of us could explain how Kevin's signature had appeared on documentation for a body that officially didn't exist. The next morning, our attendance sheets showed 5 names instead of 4. The addition was subtle, a name inserted between Amanda's and Tyler's entries as if it had always been there. Marcus Reed, written in the same careful handwriting we used for our own signatures. The student ID number followed the proper format, and the name was marked present for every session we'd attended. Who's Marcus Reed? Dr. Foster asked during roll call, looking directly at our group. None of us recognized the name, yet when I looked at the attendance sheet, it seemed perfectly natural that it should be there. Like spotting a typo that your brain corrects automatically, the presence of a 5th name felt simultaneously wrong and inevitable. That afternoon, during our cardiovascular dissection work, Tyler made an observation that chilled all of us to silence. The heart, he said, pointing to the organ he'd carefully extracted and positioned for examination. Look at the muscle development around the left ventricle. The cardiac muscle showed clear evidence of athletic conditioning, the kind of hypertrophy associated with endurance training. But there was also scarring consistent with a minor myocardial infarction, probably sustained several years before death. Marathon runner, Amanda said immediately. Probably had a heart attack during training, recovered. Kept running anyway. We all nodded in agreement. Though none of this information appeared in the documentation we didn't have for the body that wasn't supposed to exist. I ran marathons in college, Kevin said quietly. Had chest pains during a training run junior year. Doctor said it was probably nothing, but I always wondered. The room fell silent except for the hum of the ventilation system cycling stale air. That evening, I stayed late in the library researching cardiac pathology, trying to understand what we'd observed. When I finally returned to the anatomy lab to collect notes I'd left behind, I found someone working at our table, a 5th student, bent over the cadaver with the focused attention of someone deeply engaged in anatomical study. He looked up as I approached, and I recognized the face immediately, not because I'd seen it before, but because I'd been looking at its dissected form for 3 weeks. "You're early for tomorrow's session," he said, his voice carrying the casual familiarity of someone I'd known for years. "Want to review the hepatic portal system? I think Dr. Foster is going to focus on that during the exam." I stood there, unable to speak, looking at Marcus Reed, a student who didn't exist in any official record, studying a body that had no documentation, in a lab that was supposed to be locked after hours. "Oh," he said, noticing my expression. "You can see me now. That's interesting. Usually takes longer for the recognition to develop." He straightened up, and I realized he was exactly my height, with the same build, the same general coloring. Like looking at myself through a filter of possibility. "Don't worry," Marcus said, returning his attention to the cadaver that wore his face. "You'll understand everything once the course is complete. We all do eventually." Behind him, the body on the table moved slightly. Not the movement of living tissue, but the subtle shift of someone adjusting position to relieve pressure on uncomfortable joints. I left the lab and haven't returned for evening sessions since. But every morning, Marcus Reed's name appears on our attendance sheet, marked present. And every day, Kevin looks a little more like the face we've been dissecting, as if proximity to death is teaching him how to wear it properly. Sometimes I wonder if anatomy class is really about learning how the body works, or learning how to recognize the body you're going to become. The Advanced Patient Simulation Laboratory at Hartwell Medical College represented the cutting edge of medical education technology. 24 high-fidelity mannequins, each capable of simulating virtually any physiological condition, occupied individual testing bays equipped with full monitoring equipment and life support systems. The mannequins could breathe, bleed, develop symptoms, and even die in response to treatment decisions, all controlled by sophisticated computer programs designed to replicate real-world medical scenarios. My assigned simulator for basic life. Support certification was Station Door 11, a adult male mannequin designated Patient Harrison. The face was generically handsome in the way of department store mannequins, with features designed to be unmemorable and non-threatening. The skin felt remarkably realistic, slightly cool to the touch, with the appropriate texture and give of human tissue. Dr. Patricia Vance supervised our BLS practical examinations, with the methodical attention to detail that had made her the simulation lab's most respected instructor. Remember, she announced to our group of 8 students, these scenarios are designed to test your technical skills and decision-making under pressure. The mannequins will respond exactly as a real patient would. Treat them accordingly. My scenario was straightforward. Adult male, unresponsive, no pulse detected. Begin CPR immediately and continue until emergency medical services arrive or the patient shows signs of recovery. Standard protocol, practiced dozens of times during our training sessions. I positioned myself properly at patient Harrison's side, placed my hands in the correct position on his chest, and began the compression sequence. 30 compressions, 2 rescue breaths, repeat. The mannequin's chest rose and fell appropriately with each breath I delivered, and the monitoring equipment registered the artificial circulation I was generating. Everything proceeded normally for the first 4 cycles. During the 5th cycle, as I leaned down to deliver rescue breaths, patient Harrison exhaled. Not the passive air movement that should occur when chest compressions release pressure from the lungs, but an active exhalation, a deliberate breath out that carried with it a faint but unmistakable scent. Antiseptic mixed with something organic and stale, like air from a closed room that hadn't been ventilated in weeks. I paused, looking at Dr. Vance to see if this was part of the programmed scenario. She nodded encouragingly. "Continue with your protocol," she said. "Don't let unusual observations distract you from proper technique." I resumed CPR, but the mannequin's behavior had shifted subtly. The chest felt different under my hands, warmer, more responsive, as if circulation had actually improved. The skin tone appeared more natural, less waxy. When I delivered the next round of rescue breaths, patient Harrison's lips felt soft and warm against the pocket mask. During the 7th cycle, he whispered. The words were barely audible, delivered during the brief pause between chest compressions. "You'll need to go deeper." I stopped immediately and looked around the simulation bay. Dr. Vance was observing from her monitoring station 12 feet away, taking notes on her tablet. The other students were focused on their own scenarios. No one else seemed to have heard anything unusual. "Did you hear that?" I asked Dr. Vance. "Hear what?" She replied, looking up from her notes. The mannequin spoke. Dr. Vance frowned. "The audio system is disabled during BLS testing. These units don't have vocal capabilities activated for this scenario type." I looked down at patient Harrison. His face remained expressionless, eyes closed, no sign of the consciousness that would be required for speech. Yet I was certain I'd heard him speak, felt the vibration of his words against my hands as they rested on his chest. "Continue with your assessment," Dr. Vance instructed. "You've been performing CPR for 8 minutes. What's your next decision point?" I resumed compressions, trying to focus on technique rather than the growing certainty that something was fundamentally wrong with this simulation. Patient Harrison's body temperature continued to increase. His skin developed a faint flush consistent with improving circulation. The monitoring equipment began registering weak but detectable cardiac rhythms. "You're getting a response," Dr. Vance noted approvingly. "Good technique, but the mannequin was responding too well." Real CPR rarely produces such dramatic improvements in simulated cardiac arrest scenarios. The computer programs were designed to reflect the sobering reality of resuscitation success rates, not to provide false encouragement through unrealistic recoveries. During the 11th cycle, patient Harrison opened his eyes. This was definitely not part of the standard programming. The mannequins were equipped with eyelid mechanisms for certain advanced scenarios, but BLS testing used basic models without such features. Yet patient Harrison was looking directly at me with brown eyes that tracked my movement and reflected the overhead lighting with the subtle variations of living tissue. "You'll need to go deeper," he repeated, his voice now clearly audible though his lips didn't move. I looked frantically at the monitoring station. Dr. Vance continued taking notes, apparently unaware of any anomaly in the simulation. The audio recording system showed no unusual activity. a steady flat line indicating no sound input. "Dr. Vance," I called out. "There's definitely something wrong with this unit." She approached the simulation bay and observed patient Harrison, whose eyes had closed again and whose skin had returned to the appropriate mannequin pallor. "Everything appears normal," she said after a brief examination. "Are you experiencing test anxiety? That's very common during practical examinations." I wanted to argue, to insist that the mannequin had been speaking and moving independently, but the evidence contradicted my experience. Patient Harrison lay motionless and silent, exactly as a training mannequin should. "Continue with your protocol," Dr. Vance instructed. "You have 3 more minutes to complete the scenario." I resumed CPR, but my hands were shaking now. Each compression felt like pressing against living tissue that responded with the subtle give and rebound of actual human physiology. The rescue breath seemed to be drawn into functioning lungs that processed oxygen and expelled carbon dioxide in patterns I could sense but not explain. With 30 seconds remaining in the scenario, I leaned down for the final round of rescue breaths. As my face approached the pocket mask, patient Harrison whispered again, his voice so close I could feel warm breath against my ear. "You'll need to go deeper," he said. But this time the voice was my own. I jerked back, staring at the mannequin's face. The features had subtly shifted, becoming more familiar. Not dramatically different, but closer to my own bone structure, my own coloring. Like looking at myself after a serious illness or injury had changed the fundamental architecture of my face. The timer buzzed, indicating the end of the scenario. Dr. Vance approached with her tablet, ready to provide feedback on my performance. "Excellent work," she said, consulting her notes. "You maintained proper form throughout the scenario, and the audio monitoring system recorded some very interesting vocalizations during your rescue breathing technique." "Audio monitoring?" I asked. She showed me the playback screen on her tablet. A waveform display showed my voice at regular intervals throughout the CPR session, saying the same phrase over and over. "You'll need to go deeper." "I never said that," I protested. Dr. Vance looked puzzled. "The system recorded 37 instances of that exact phrase, always during rescue breath delivery." "Are you sure you weren't talking yourself through the procedure?" "Many students do that unconsciously." I listened to the playback. The voice was unmistakably mine, but I had no memory of speaking during the simulation. Each repetition was clear and deliberate, as if I'd been coaching myself through some technique that required greater intensity or commitment. Since that day, I've avoided the simulation lab whenever possible. But sometimes, during other practical exercises or clinical rotations, I catch myself whispering, "You'll need to go deeper," without conscious intention. Usually when I'm working with unconscious patients, or when I'm alone in examination rooms preparing for procedures. The phrase has become involuntary, like a medical student's version of a nervous tic. But I'm starting to understand what it means, that successful medical practice requires a willingness to penetrate deeper into human suffering than most people can psychologically tolerate. The mannequins, it seems, are designed to teach us more than just technical skills. They're preparing us for the depth of engagement that real medicine demands, even if we're not ready to acknowledge what that preparation entails. Dr. Elizabeth Morgan had been supervising psychiatric ward rotations at St. Catherine's Medical Center for 17 years, long enough to have developed an intuitive sense for which medical students would thrive in mental health care, and which would struggle with the emotional demands of the specialty. During my third-year clinical rotations, she paired me with her most challenging cases, patients whose presentations defied easy categorization and whose treatment required the kind of nuanced understanding that separated competent physicians from exceptional ones. The psychiatric ward at St. Catherine's occupied the entire 4th floor of the hospital's east wing. Unlike the controlled chaos of emergency departments or the technological sophistication of intensive care units, the psychiatric ward maintained an atmosphere of deliberate calm. Soft lighting, muted colors, and sound-dampening materials created an environment designed to reduce stimulation and promote therapeutic interaction. My rotation began with orientation to the ward's protocols and patient population. 36 beds housed individuals experiencing acute psychiatric crises, severe depression, bipolar disorder, schizophrenia, substance-induced psychosis. and various personality disorders requiring intensive stabilization. The nursing staff moved through their responsibilities with the particular blend of compassion and clinical detachment that characterizes effective psychiatric care. It was during my second week that Dr. Morgan assigned me to shadow her consultation with patient 4B, a 34-year-old woman admitted 3 days earlier following a suicide attempt. The patient, identified in her chart as Linda Garrett, had been found unconscious in her apartment after ingesting a lethal combination of prescription medications. Emergency intervention had prevented permanent physical damage, but her mental state remained severely compromised. She's been largely non-responsive since admission, Dr. Morgan explained as we reviewed the case notes outside Linda's room. Minimal verbal interaction, no eye contact, classic presentation of severe major depressive episode with psychotic features. We've started her on antipsychotic medication, but it's too early to assess effectiveness. Linda sat motionless in the bedside chair when we entered her room, her gaze fixed on some undefined point near the window. Her posture suggested complete withdrawal from external stimuli, shoulders hunched, hands folded tightly in her lap, breathing shallow and irregular. The medication had clearly sedated her to some degree, but her stillness went beyond pharmacological effect. Dr. Morgan began her standard assessment routine, asking open-ended questions about Linda's emotional state, her understanding of her current situation, and her thoughts about treatment goals. Linda's responses consisted entirely of single-word answers or prolonged silence. After 20 minutes of gentle but persistent inquiry, Dr. Morgan concluded the session. "We'll continue with the current medication regimen and reassess tomorrow," she told me as we left Linda's room. Severe depression often requires patience. The therapeutic relationship develops slowly. That evening, I returned to the ward to complete patient observation logs required for my rotation documentation. The fourth floor after 9 p.m. took on a different character, quieter, with reduced lighting and minimal staff activity. Night shift nurses conducted their rounds with practiced efficiency, checking on patients who were supposed to be sleeping under the influence of sedative medications. Linda's room was my final stop. I expected to find her lying motionless in bed, but instead she remained in the bedside chair, maintaining the same position she'd held during Dr. Morgan's assessment 8 hours earlier. As I approached to check her breathing and general status, Linda began speaking, not the hesitant monosyllabic responses she'd given Dr. Morgan, but a clear, continuous recitation delivered in a steady, mechanical tone. She was quoting directly from my psychiatric medicine textbook, Chapter 7, Section 3, covering the neurobiological basis of major depressive disorder. Dysregulation of monoaminergic neurotransmitter systems, particularly serotonin, norepinephrine, and dopamine, contributes to the pathophysiology of major depressive episodes, Linda recited without inflection. Neuroimaging studies demonstrate decreased activity in prefrontal cortical regions responsible for executive function and emotional regulation. I stopped walking, convinced I was mishearing or misinterpreting her words, but Linda continued with perfect accuracy, reciting complex neurochemical concepts that would challenge graduate-level psychology students. The hypothalamic pituitary adrenal axis shows characteristic hyperactivation in severe depression, resulting in elevated cortisol levels and disrupted circadian rhythm regulation, she continued, her voice maintaining the same flat, emotionally empty delivery. These weren't concepts a typical patient would know. Linda's admission records showed she worked as a retail manager with no medical or scientific background, yet she was delivering a word-for-word recitation of advanced psychiatric medicine content. I approached her chair slowly, watching for any sign of awareness of my presence. Linda's eyes remained focused on the window, her posture unchanged, but her recitation shifted to content I recognized from my own handwritten study notes. Differential diagnosis must exclude medical conditions that can mimic psychiatric presentation, she said, now quoting notes I'd written during Dr. Morgan's lectures the previous week. Thyroid dysfunction, vitamin B12 deficiency, and temporal lobe epilepsy require investigation before confirming primary psychiatric etiology. My handwriting was distinctive, a compressed script that professors often criticized for illegibility. Yet Linda was reciting my personal interpretations and observations with perfect accuracy, including abbreviations and marginal comments I'd made while studying. "Linda," I said softly. She turned toward me for the first time since her admission. making direct eye contact with an intensity that contrasted sharply with her previous withdrawal behavior. "Stop studying," she said, her voice suddenly clear and urgent. "It won't save you." Then she returned to the textbook recitation as if the personal comment had never occurred. I backed out of the room and found the night shift charge nurse, Rebecca Hayes, completing medication distribution in the hallway. "Has Linda been talking tonight?" I asked. Rebecca looked surprised. "Linda?" "She hasn't said a word since admission." "Are you sure you have the right room?" I led Rebecca back to Linda's room, expecting to find her continuing the psychiatric lecture. Instead, Linda sat in complete silence, her previous stillness restored. Rebecca conducted a quick assessment, checking Linda's responsiveness and medication compliance. "Still nonverbal," Rebecca confirmed. "Classic catatonic presentation. The medication should help, but it takes time." After Rebecca left, I remained in Linda's doorway for several more minutes. Linda gave no indication of awareness of my presence, no sign of the medical knowledge she'd demonstrated moments earlier. The next morning, I mentioned the incident to Dr. Morgan during our case review meeting. "Auditory hallucinations aren't uncommon during psychiatric rotations," she said with understanding. "The emotional intensity of this work affects students in various ways. Sometimes we project our own stress into patient interactions. But when I opened my psychiatric medicine textbook that afternoon to review material for an upcoming examination, I found Linda's name written inside the front cover, not in my handwriting, but in the careful cursive script that characterized her signature on admission forms. Below her name, in the same handwriting, was a single sentence: "Some knowledge transfers in ways the textbooks don't explain." I hadn't written those words. I was certain of that, yet the ink matched my study pen, and the page showed no signs of tampering or alteration. That evening, I returned to Linda's room to test my growing suspicion that something impossible was occurring. I brought a different textbook, cardiovascular medicine, and sat reading silently in the chair beside her bed. After 20 minutes, Linda began reciting cardiovascular pathophysiology content, again with perfect accuracy and the same emotionally flat delivery. When I switched to surgical technique materials, she shifted to surgical procedures. Each transition occurred within seconds of my changing focus, as if she was reading directly from my mind. "How are you doing this?" I whispered. Linda turned toward me with that same penetrating eye contact. "You're learning to see inside people," she said, "but you haven't learned to protect yourself from what you see. Some patients study you back. Since that night, my study habits have changed dramatically. I no longer review medical materials in patient areas, and I've developed the habit of clearing my mind before entering psychiatric ward environments. But sometimes when I'm alone with textbooks late at night, I hear Linda's voice reciting content I haven't read yet. Chapters scheduled for next semester. Treatment protocols for conditions I haven't studied. Medical education, I'm beginning to understand, creates connections between minds that persist beyond the formal learning environment. Sometimes the patients teach us more than we teach them, though the lessons aren't always ones we're prepared to receive. The knowledge flows both ways, and the price of learning to see inside human suffering is learning to live with what sees back. Internal medicine rotation at University Medical Center represented my first substantial exposure to the diagnostic reasoning that separates competent physicians from exceptional ones. Dr. Sarah Chen, the attending physician overseeing my rotation, emphasized the importance of meticulous patient monitoring and thorough documentation, skills that would prove essential regardless of whatever specialty I eventually chose. The rotation schedule placed me on the medical ward from 6 a.m. to 6 p.m., Monday through Friday, with additional on-call responsibilities every fourth night. The pace was demanding but educational, requiring quick adaptation to multiple patient cases while maintaining the detailed attention to clinical changes that characterizes effective internal medicine practice. It was during my second week that we admitted the patient who would fundamentally challenge my understanding of medical record-keeping and patient accountability systems. The young man arrived via emergency department transfer on a Tuesday evening, approximately 11:30 p.m. according to the admission timestamps. Mid-20s, well-nourished, no obvious signs of acute distress. Chief complaint listed as general malaise and intermittent chest discomfort. Vital signs were remarkably normal. Blood pressure 120/80, heart rate 72, temperature 98.6 degrees, oxygen saturation 99% on room air. What made the case unusual wasn't the patient's presentation, but the complete absence of identifying information in his medical record. The admission form showed blanks where name, date of birth, insurance information, and emergency contacts should appear. Even more puzzling, no one could remember who had authorized the admission or which emergency department physician had conducted the initial evaluation. Probably a documentation error, Dr. Chen said when I brought the anomaly to her attention during morning rounds. It happens more often than we'd like to admit. The night shift was busy. Someone forgot to complete the paperwork properly. We'll sort it out. The patient occupied room 314, a semi-private space that he shared with an elderly gentleman recovering from pneumonia. When Dr. Chen and I entered for our initial assessment, the young man was sitting up in bed, reading what appeared to be a medical journal, unusual for someone without healthcare background, but not unprecedented. "Good morning," Dr. Chen began with her standard greeting. "I'm Dr. Chen, the attending physician, and this is my student. How are you feeling today?" The patient looked up from his reading material and smiled pleasantly. "Much better, thank you. I appreciate the excellent care." His voice was clear and articulate, with no signs of the confusion or disorientation that might explain the documentation problems. Dr. Chen conducted a systematic physical examination, finding no abnormalities in cardiovascular, respiratory, neurological, or gastrointestinal systems. "We'll need to run some routine laboratory tests," Dr. Chen explained, "and we'll need to get your insurance information sorted out for proper billing." "Of course," the patient agreed. "Whatever you think is necessary." But when the phlebotomist arrived to collect blood samples, the patient was gone. Not discharged, not transferred to another unit, simply absent from room 314. His bed remained unmade, with obvious indications that someone had been occupying it recently. The mattress still bore the impression of a human form, and the bedside table held the medical journal he'd been reading. Dr. Chen checked with the nursing staff, but no one had observed the patient leaving. The electronic monitoring system showed no record of him exiting the room or the floor, yet room 314 stood empty except for the elderly pneumonia patient, who insisted he'd never had a roommate. There was no one in the other bed. The elderly patient told us with conviction, "I've been alone in this room since admission." The medical record system showed contradictory information. The admission forms remained in the database, time-stamped, and filed properly, but the patient identification fields had somehow become corrupted. Where a name should appear, the system displayed only "patient unassigned, pending verification." Laboratory orders had been entered and processed, but the blood samples had never been collected. More puzzling, the lab results were already available in the system, showing completely normal values across all requested parameters. Someone had run tests on blood that had never been drawn from a patient who couldn't be identified. "System glitch," Dr. Chen concluded after consulting with the IT department. "The hospital's electronic health record has been acting up lately. Probably some kind of database synchronization error." But the next morning, the patient was back. Same room, same bed, same pleasant demeanor. When Dr. Chen asked about his disappearance the previous day, he seemed genuinely confused. "I've been here continuously since admission," he said. "I think there might be some confusion in your records." The nursing staff confirmed that room 314 had been occupied all night, though none of them remembered checking on the patient or documenting his vital signs. Yet the computerized charting system showed detailed nursing notes at appropriate intervals, including assessments of his neurological status, pain levels, and medication compliance. All the nursing notes were signed with my name. I hadn't written any nursing documentation. Medical students don't have access to the nursing charting system, and I'd never been trained on the software interface. Yet there were 8 detailed entries over the previous 24 hours, each one professionally written and clinically appropriate, each one bearing my electronic signature. "Did you write these?" Dr. Chen asked, showing me the nursing notes on her tablet. I examined the entries carefully. The handwriting style matched my own, and the observations reflected the kind of detailed attention to patient condition that characterized my approach to clinical documentation. But I had no memory of writing any of it. "I don't think so," I said, "but they look like something I might write." The pattern continued for 6 days. Each morning, the patient would be present in room 314, pleasant and cooperative during our assessments. Each afternoon, he would vanish without explanation, leaving behind only the evidence of his occupation: warm bed sheets, personal items, and updated medical records that no one remembered creating. The electronic health record began showing test results that hadn't been ordered, consultation notes from specialists who hadn't seen the patient, and progress notes documenting treatment decisions that hadn't been made. All the documentation bore appropriate signatures and timestamps, creating a comprehensive medical record for care that hadn't been provided. By the end of the week, I started staying late to observe room 314 during the evening hours when the patient typically disappeared. On Thursday night, I positioned myself at the nursing station with a clear view of the room's entrance. At approximately 8:30 p.m., I watched the patient walk out of room 314 and proceed toward the elevator bank. Nothing unusual about his movement or behavior. He appeared to be a typical ambulatory patient going for a walk or visiting the cafeteria. I followed him to the elevators, maintaining a discreet distance. When the elevator doors opened, the patient stepped inside, turned around, and looked directly at me. "You're very thorough," he said as the doors began to close. "I appreciate that in a physician." The elevator descended to the lobby level. When I took the next elevator down and checked the lobby, security desk, and main entrance, there was no sign of him anywhere. But when I returned to the fourth floor, room 314 was occupied again. The patient sat in bed, reading the same medical journal as if he'd never left. "Good evening," he said pleasantly. "Working late?" I stared at him, trying to process what I'd just witnessed. "I saw you get on the elevator." "I don't think so," he said. "I've been reading here for the past hour." The next morning, Dr. Chen announced that we needed to discharge the patient. "Whatever was wrong with him seems to have resolved," she said. "All his test results are normal, and he's been stable for a week. There's no medical justification for continued hospitalization." But when we arrived at room 314 to complete the discharge process, we found the bed empty and professionally made, as if no one had occupied it recently. The patient's belongings were gone, and there was no indication that anyone had been staying in the room. More disturbing, the medical record had changed. Where the patient's name should appear, the system now displayed my full name, first, middle, and last, spelled exactly as it appeared on my medical school identification. The admission date matched my first day of internal medicine rotation. The discharge date was automatically populated as my last scheduled day on the service. Every piece of documentation in the record, the nursing notes, the laboratory results, the progress notes, was signed with my name and student ID number. According to the medical record, I had been the patient all along. Dr. Chen seemed to find nothing unusual about this development. "Interesting case," she said, reviewing the documentation on her tablet. "You did excellent work documenting your own care. Very thorough, very professional. This kind of attention to detail will serve you well in whatever specialty you choose." I wanted to object, to point out the impossibility of the situation, but the evidence was overwhelming. The medical record clearly showed that I had been admitted to room 314, had received a week of internal medicine care, and had been successfully treated for unspecified symptoms. I didn't remember being a patient. I remembered being a medical student, conducting assessments, writing progress notes, learning from Dr. Chen's expertise. But the official documentation told a different story, and in medicine, documentation always takes precedence over memory. Since completing that rotation, I've developed the habit of double-checking my name on all medical records I encounter. Sometimes I find it in places I don't expect: patient lists for services I haven't worked, surgical schedules for procedures I haven't observed, even death certificates for cases I haven't been involved with. Medical record systems, I've learned, sometimes document possibilities rather than actualities. They track not just what has happened, but what might happen, what could happen, what will eventually happen to people who spend too much time in hospitals. The line between being a medical student and being a patient turns out to be more permeable than anyone admits during orientation. Sometimes the records know things about our futures that we haven't learned yet ourselves. Professor Emeritus Dr. Edmund Blackwood had taught pathology at Wellington Medical College for 43 years before his official retirement, though no one seemed entirely clear on when that retirement had actually occurred. Students and faculty alike continued to encounter him in the pathology department's specimen vault at all hours, particularly during the night shift when the building's older sections took on an atmosphere of scholarly solitude. The specimen vault occupied the basement level of the medical school's original building, a space that had been expanded and renovated multiple times over the decades to accommodate the growing collection of preserved tissues, organ samples, and pathological specimens used for educational purposes. Hundreds of glass jars lined floor-to-ceiling shelving units, each containing carefully preserved examples of human pathology in various stages and presentations. Dr. Blackwood's presence in the vault had become something of an institution. Younger faculty members assumed he maintained emeritus privileges that allowed him continued access to research materials. Students accepted his after-hours consultations as an unofficial extension of the pathology curriculum. No one questioned his right to be there, partly because his knowledge of the collection was encyclopedic, and partly because asking about Professor Blackwood's status felt somehow inappropriate. I first encountered him during my second-year pathology course, while researching a presentation on cardiac pathology. The vault's climate-controlled environment and comprehensive cataloging system made it an ideal location for intensive study, particularly during evening hours when undergraduate traffic was minimal. Dr. Blackwood stood near the cardiovascular specimen section, apparently conducting a detailed examination of preserved heart tissue samples. He was exactly as students had described him: tall, thin, with the sort of academic bearing that suggested decades of scholarly dedication. His lab coat was impeccably maintained, and he handled the specimen jars with the reverential care of someone who understood their educational value. "Fascinating examples," he said without turning around, apparently aware of my presence, despite my attempt to enter quietly. "This particular specimen shows classic presentation of hypertrophic cardiomyopathy with asymmetric septal involvement." I approached the display case he was examining, expecting to see the type of detailed pathological changes he was describing. Instead, the jar contained what appeared to be a normal heart, with no obvious signs of disease or structural abnormality. "I'm not seeing the pathological changes," I admitted. Dr. Blackwood turned toward me with a gentle smile. "Look more carefully," he suggested. "Pathology often reveals itself gradually to the properly trained eye." He began pointing out features I had missed: subtle thickening of the ventricular wall, minor asymmetries in chamber proportions, early-stage fibrotic changes that would eventually progress to clinical significance. Under his guidance, the specimen transformed from unremarkable tissue to a textbook example of cardiovascular pathology. "They remember everything," Dr. Blackwood said softly, replacing the jar on its shelf with careful precision. "Every diagnosis, every student who studied them, every insight they've provided. The specimens are teachers in their own right." I assumed he was speaking metaphorically about the educational value of the pathology collection, but as he moved through the vault, examining different specimens, I noticed he seemed to be conducting conversations rather than examinations. Soft words directed toward each jar, pauses as if listening to responses, gentle nods of understanding or agreement. "Dr. Blackwood," I said, uncertain how to phrase my question appropriately. "They remember you now," he said, turning back toward me with that same gentle smile. "You've been respectful, attentive. That matters more than you might think." The comment seemed oddly personal, but I attributed it to the particular way elderly academics sometimes developed attachments to their teaching materials. Dr. Blackwood had spent decades working with these specimens. It was natural that he would have developed a sense of personal connection to the collection. Over the following weeks, I returned to the specimen vault regularly, often encountering Dr. Blackwood during my study sessions. He was invariably helpful, providing insights and explanations that went far beyond standard textbook presentations. His knowledge seemed to encompass not just pathological processes, but the personal histories of the specimens, where they had been obtained, what cases they represented, how they had been used in previous educational contexts. "This one came from a 47-year-old carpenter," he would say, indicating a liver specimen. "Chronic alcohol use developed cirrhosis over 15 years. donated his organs for medical education because he wanted his death to serve some useful purpose. The level of detail was remarkable, though I wondered how Dr. Blackwood could remember such specific information about so many specimens collected over decades of teaching. It was during my pathology final examination that I discovered the true nature of our relationship. The practical examination required identifying 50 different specimens and providing appropriate diagnostic information, standard format for pathology courses. Students moved through the specimen displays, recording their observations and conclusions on answer sheets that would be reviewed by faculty members. I approached the first station with confidence, having spent considerable time studying the collection under Dr. Blackwood's guidance. The specimen was one I recognized immediately, a kidney showing chronic pyelonephritis with characteristic scarring patterns. Before I could complete my written response, the answer filled itself in on my answer sheet, not in my handwriting, but in the precise, scholarly script I'd seen Dr. Blackwood use when making notes during our study sessions. The diagnosis was correct, the supporting observations were thorough, and the clinical correlation was exactly what I would have written, given more time and confidence. I looked around the examination room. No other students seemed to notice anything unusual about my answer sheet. The proctor, Dr. Miranda Walsh, was stationed across the room, observing the examination process with appropriate professional detachment. The pattern continued at each station. As I examined specimens, appropriate answers appeared on my sheet in Dr. Blackwood's handwriting. Not just basic identifications, but detailed pathophysiological explanations that demonstrated graduate-level understanding of disease processes. By the end of the examination, my answer sheet was complete with responses I hadn't written, displaying knowledge I didn't possess. The handwriting was consistent throughout, Dr. Blackwood's distinctive style, with the characteristic flourishes and abbreviations I'd observed during our study sessions. When Dr. Walsh collected the examination materials, she paused at my answer sheet. "Interesting handwriting," she commented. "Very similar to Professor Blackwood's style. Did he provide you with additional tutoring?" "We studied together in the specimen vault," I said. Dr. Walsh looked puzzled. "Professor Blackwood? He's been dead for 12 years. Heart attack in his office right here in the pathology department." I stared at her, certain there had been some mistake. "I've been studying with him for weeks. He's been helping me understand the specimen collection." "That's not possible," Dr. Walsh said gently. "Professor Blackwood died in 2011, but his teaching methods have influenced the pathology curriculum for years. Students often say they feel his presence in the specimen vault." That evening, I returned to the vault to confirm what Dr. Walsh had told me. The space was empty, silent except for the hum of climate control systems. But as I moved through the specimen displays, I began to notice small cards attached to each jar, handwritten notes providing the kind of detailed background information Dr. Blackwood had shared during our study sessions. The cards were dated from the weeks I'd been studying in the vault. All were written in Dr. Blackwood's distinctive handwriting. Each one was signed with my name, as if I had been taking dictation during conversations I didn't remember having. The specimens themselves seemed different now, more active, somehow as if they were aware of being observed. When I looked carefully at the pathological changes, I could see exactly what Dr. Blackwood had been pointing out, though the features hadn't been visible to me before our study sessions. Sometimes, late at night when I'm reviewing pathology materials, I still hear Dr. Blackwood's voice providing explanations and insights. The specimens in the vault continue to reveal new details each time I study them, as if they're teaching me directly rather than serving as passive examples of disease processes. Medical education, I've learned, sometimes involves learning from teachers who have moved beyond the traditional boundaries of instruction. The knowledge they provide is no less valuable for being impossible to explain through conventional means. Some lessons, it seems, transcend the limitations of life and death. Night shifts during third-year clinical rotations exist in a liminal space between medical education and endurance testing. The call rooms at Metropolitan General Hospital were designed as functional spaces for brief rest periods during extended duty hours. Small, windowless chambers equipped with narrow beds, basic storage, and minimal amenities. The goal was restorative sleep measured in minutes rather than hours. Power naps that would sustain cognitive function through the remainder of overnight responsibilities. Call Room 7, located on the 4th floor of the hospital's East Wing, had been my assigned rest space during internal medicine rotation for 3 weeks. The room was identical to the others, 8 feet by 10 feet, containing a single bed, a built-in desk, a small closet, and a compact wash basin. The institutional decor was aggressively neutral, designed to facilitate sleep rather than comfort. The closet door had developed a peculiar characteristic during my 2nd week using the room. It wouldn't stay completely closed, despite multiple attempts to adjust the latch mechanism. The door would swing partially open during rest periods, creating a gap of approximately 6 inches that allowed hospital corridor light to penetrate the room's deliberately dim environment. Maintenance had examined the door twice, finding no mechanical defect in the latch system. Probably building settlement, the lead technician explained. These older hospital sections shift over time. Nothing that would affect the room's functionality. The partially open closet door became part of my routine. I'd enter the call room after completing evening rounds, attempt to close the closet properly, accept that it would drift open again, and arrange myself for whatever brief sleep period my rotation schedule allowed. It was during my 4th week that I began hearing sounds from inside the closet. Not dramatic sounds, no crashes or voices or obvious signs of intrusion, just gentle movement, like someone shifting position in a confined space, or fabric rustling against fabric. The sounds occurred only during my rest periods, never when I was actively moving around the room. Sleep deprivation can generate auditory hallucinations, particularly during the microsleep episodes that characterize severe exhaustion. Medical students learn to recognize these phenomena as normal physiological responses to extended wakefulness rather than indications of underlying pathology. On Thursday night, following a particularly demanding day in the emergency department, I collapsed onto the call room bed without bothering to remove my shoes or stethoscope. The familiar weight of the stethoscope around my neck had become comforting, a tangible reminder of my developing medical identity. I awakened 3 hours later to the sound of knocking. Not knocking on the call room door, which would indicate someone needing my assistance with patient care responsibilities. This knocking came from inside the closet, gentle but persistent, like someone requesting permission to exit. I sat up on the bed, listening carefully to determine if the sound was real or a product of disrupted sleep architecture. The knocking continued, 3 taps, pause, 3 taps, pause, in a pattern that suggested intentional communication rather than random noise. "Hello?" I called softly, feeling foolish for addressing an empty closet. The knocking stopped immediately. I approached the closet door and pulled it fully open, expecting to find nothing more than the few personal items I stored there. Spare scrubs, a lab coat, and a small bag containing toiletries and study materials. Instead, my stethoscope hung from the closet rod. This was impossible. My stethoscope was around my neck. I could feel its familiar weight, see the earpieces in my peripheral vision. Yet an identical stethoscope hung inside the closet, suspended from what appeared to be an improvised noose made from its own tubing. I reached up to touch the stethoscope around my neck, confirming its presence. Then I examined the one in the closet more carefully. Same model, same wear patterns, same small scratch on the chest piece that I'd noticed during my first week of clinical rotations. 2 identical stethoscopes, both unmistakably mine. I removed the hanging stethoscope from the closet rod and examined it closely. The serial number matched my own instrument exactly. The personalized engraving on the chest piece, a graduation gift from my parents, was identical in every detail. But when I set the hanging stethoscope on the desk and turned back to close the closet door, I found it hanging there again, suspended in the same position, tied with the same careful knots. Over the following nights, the pattern repeated itself. Each time I entered the call room, I would find my stethoscope hanging in the closet, fashioned into a loop with professional precision. Each time I would remove it and attempt to dispose of it, placing it in medical waste containers, leaving it at the nurse's station, even taking it home to throw away in my apartment's dumpster. But every morning, the stethoscope would be around my neck again, warmed as if I'd been wearing it for hours. The warmth was the most disturbing aspect of the phenomenon. Medical instruments stored in hospital environments typically feel cool to the touch, equilibrating to room temperature overnight. but my stethoscope each morning carried the warmth of sustained contact with human skin, as if someone had been wearing it through the night. I began documenting the pattern in a small notebook, recording the exact time I would find the hanging stethoscope, the precise configuration of the knots, and any variations in the phenomenon. The knots showed increasing sophistication over successive nights, simple loops initially, progressing to complex configurations that would require medical training to execute properly. On my final night of internal medicine rotation, I decided to stay awake and observe the closet directly, hoping to understand the mechanism behind what I was experiencing. I positioned myself at the desk with a clear view of the closet interior and maintained vigilance through the night shift. At approximately 3:30 a.m., during the hospital's quietest period, I watched my stethoscope materialize inside the closet. Not dramatically, there was no flash of light or sudden appearance. Instead, the stethoscope seemed to condense gradually from the air inside the closet, like moisture forming on a cold surface. As it became more solid, it arranged itself into the familiar hanging configuration, the tubing forming loops with the practiced precision of someone who had performed the action many times before. The process took approximately 15 minutes from initial manifestation to complete formation. During that time, I remained perfectly still, afraid that any movement might disrupt whatever phenomenon I was witnessing. When the stethoscope had fully materialized and positioned itself, it began to move slightly, as if responding to air currents that didn't exist in the windowless, climate-controlled call room. I approached the closet slowly, watching the hanging stethoscope's gentle movement. As I reached toward it, intending to document its physical properties more thoroughly, the stethoscope around my neck began to warm noticeably. Not the gradual warming of contact with body heat, but an immediate, substantial increase in temperature that bordered on uncomfortable. The chest piece against my skin became hot enough to cause concern about thermal injury. I stepped back from the closet, and the temperature of my stethoscope returned to normal. Since completing that rotation, I've changed my approach to medical instruments. I now use different stethoscopes for different rotations, never becoming too attached to any particular piece of equipment. But regardless of which stethoscope I choose, it develops the same characteristics over time: the warming effect, the tendency to appear in unexpected locations, the sense that it's being used for purposes I don't remember. Medical instruments, I've learned, sometimes develop their own relationships with the work they're designed to facilitate. They become connected to the diagnostic process in ways that extend beyond their mechanical function, forming bonds with the physicians who use them that persist even when we're not consciously engaged in patient care. The stethoscope around my neck right now is warming as I write this, as if it approves of my documentation of these experiences. Sometimes I think it's teaching me to listen more carefully, not just to heart sounds and lung sounds, but to the subtler communications that occur between medical instruments and the human suffering they're designed to detect. Some tools, it seems, continue working even when we think we've put them aside. The Regional Burn Center at St. Mary's Hospital represented one of the most emotionally challenging clinical rotations available to fourth-year medical students. The unit treated severe thermal injuries requiring specialized care, patients whose survival often depended on meticulous wound management, infection control, and psychological support through extended recovery periods. The work demanded a particular kind of professional detachment, the ability to provide compassionate care while maintaining the emotional distance necessary for clinical decision-making. Dr. Patricia Wells, the burn unit's medical director, had spent 15 years developing protocols that balanced aggressive treatment with realistic outcome expectations. She emphasized to rotating students that burn care required acceptance of limitations, understanding that despite optimal medical intervention, some injuries exceeded the body's capacity for recovery. Detachment isn't callousness, Dr. Wells explained during my orientation to the unit. It's survival. If you absorb every patient's suffering, you'll burn out before you complete your training. Professional distance protects both you and your patients. The burn unit occupied a dedicated wing of the hospital's 4th floor, with specialized rooms equipped for sterile wound care, pain management, and intensive monitoring. 12 beds accommodated patients with varying degrees of thermal injury, from minor cases requiring brief observation to critical presentations demanding weeks of comprehensive care. My rotation began with standard responsibilities: wound assessment documentation, medication administration assistance, and patient monitoring under direct supervision. The work was methodical and demanding, requiring attention to detail that would prove essential regardless of whatever medical specialty I eventually chose. It was during my second week that I was assigned to assist with the care of patient 4A, a 34-year-old woman admitted following a house fire. The thermal injuries covered approximately 60% of her body surface area, primarily second and third degree burns affecting her torso, arms, and face. The presentation was severe enough to require intensive care protocols, but not immediately life-threatening if proper wound management and infection prevention measures were maintained. The patient, identified in her medical record as Helen Morrison, had been unconscious since admission due to smoke inhalation and necessary sedation for pain management. She required mechanical ventilation, continuous cardiac monitoring, and frequent assessment of wound healing. Progress. What made Helen's case unusual was the way her cardiac monitor responded to my presence in the room. During routine, vital sign checks conducted by nursing staff, Helen's monitor displayed the expected patterns for someone in her condition: elevated heart rate consistent with physiological stress, irregular rhythm reflecting the metabolic demands of extensive wound healing, occasional variations that required adjustment of medication dosages. But when I entered her room, the monitor showed dramatically different readings. Helen's heart rate would drop to normal resting levels between 60 and 70 beats per minute and maintain perfect regularity as long as I remained in the room. The cardiac rhythm became textbook normal, with none of the stress-related irregularities that characterized her baseline presentation. Dr. Wells noticed the pattern during our third week of working together. "Interesting response," she commented, observing Helen's monitor during one of my assessment periods. "Some patients do seem to respond positively to particular healthcare providers. We call it the anchor effect. Certain people provide a stabilizing influence that promotes healing. The anchor effect was a recognized phenomenon in intensive care settings. Though the underlying mechanisms weren't well understood, some patients showed measurable improvement in vital signs, pain levels, and recovery rates when specific healthcare providers were present. The effect was attributed to subtle factors: voice tone, touch pressure, personal energy, that could influence patient physiology in ways that complemented medical treatment. Helen seems to have identified you as her anchor," Dr. Wells continued. "It's actually quite beneficial for her recovery. We should incorporate your presence into her care plan." Over the following days, my schedule was adjusted to include extended periods in Helen's room. The cardiac monitoring continued to show the same pattern: dramatic stabilization whenever I was present, return to stress-related irregularities when I left. But the effect was becoming more pronounced. Helen's heart rate wouldn't just stabilize in my presence. It would synchronize exactly with my own resting heart rate. When I checked my pulse during our monitoring sessions, the rhythm matched her cardiac display precisely. Remarkable synchronization, Dr. Wells noted during one of our bedside consultations. "I've never seen the anchor effect manifest with such precision. You two seem to have developed an unusually strong physiological connection." The synchronization extended beyond heart rate. Helen's respiratory pattern, when not controlled by mechanical ventilation settings, would match my own breathing rhythm. Her blood pressure readings would fluctuate in tandem with subtle changes in my own cardiovascular status. Even her brainwave patterns, monitored due to her head injury concerns, showed correspondence with what I assumed were my own neurological rhythms. During my fourth week on the rotation, Helen began showing signs of recovery. The wound healing progressed more rapidly than expected, and her sedation requirements decreased to levels that allowed periods of consciousness. Dr. Wells was optimistic about her prognosis, attributing the improvement partly to excellent medical care and partly to the stabilizing influence of our unusual physiological connection. It was during one of Helen's conscious periods that she first spoke to me directly. "You're keeping me here," she said, her voice barely audible through the equipment supporting her breathing. I leaned closer to ensure I could hear her properly. "You're recovering well. The medical team is very pleased with your progress." "No," Helen said with more strength. "You're keeping me anchored." "I've been trying to let go, but you won't let me." The comment was puzzling. Patients recovering from severe trauma sometimes experienced confusion or disorientation, particularly when transitioning between sedated and conscious states. I attributed her words to medication effects or the psychological stress of extended hospitalization, but Helen's monitor readings during our conversation remained perfectly synchronized with my own physiological state. When my heart rate increased slightly due to concern about her mental status, her cardiac rhythm increased proportionally. When I took a deep breath to calm myself, her respiratory pattern adjusted to match. I was ready to die, Helen continued. The fire, the pain, I was ready to let go. But something keeps pulling me back. Something won't let me leave. Over the following nights, I began to understand what Helen meant. During off-duty hours, when I was at home or studying in other areas of the hospital, I would experience episodes of severe chest pain, breathing difficulties, and intense burning sensations across my skin. The symptoms would persist until I returned to Helen's room, where both her monitor readings and my physical discomfort would immediately resolve. The episodes were becoming more frequent and more intense. My resting heart rate, measured during routine health screenings, had increased to match Helen's baseline cardiac stress patterns. My sleep was disrupted by vivid dreams of fire and smoke, experiences so realistic that I would wake expecting to find burn injuries on my own body. Dr. Wells noticed the changes in my appearance and behavior. "Are you getting adequate rest?" she asked during one of our ward consultations. Burn unit rotations can be emotionally exhausting. You might benefit from a few days off. But when I tried to take time away from the hospital, the physical symptoms became unbearable. Only by returning to Helen's bedside could I find relief from the burning sensations and breathing difficulties that had begun to dominate my daily experience. On my final scheduled day of burn unit rotation, Helen's condition took an unexpected turn. Her vital signs became unstable despite optimal medical management, and her cardiac monitor began showing irregular patterns that didn't respond to medication adjustments. Dr. Wells called for intensive care consultation, but Helen's condition continued to deteriorate. The cardiac rhythms became increasingly erratic, and her blood pressure dropped to levels that suggested impending cardiovascular collapse. That's when I realized the monitor was tracking my heart rate, not Helen's. I was standing beside her bed, watching the cardiac display show the same irregular rhythms I could feel in my own chest. The burning sensations across my skin had intensified to the point where I expected to see actual thermal injuries when I looked at my arms and hands. "She's dying," Dr. Wells said quietly, preparing the equipment needed for end-of-life care protocols. But Helen opened her eyes and looked directly at me. "Thank you," she said clearly. "You can let go now." The cardiac monitor flatlined at 11:47 p.m. Felt my own heart stop at exactly the same moment. The sensation lasted for several seconds. Complete cessation of cardiac activity. No pulse, no blood pressure, the physical experience of clinical death. Then my heart resumed beating, but at Helen's previous resting rate, not my own. Since that night, my cardiac rhythm has remained synchronized with Helen's final heart rate patterns. When I check my pulse, I don't feel my own heartbeat. I feel hers, maintaining the same 67 beats per minute that characterized her last conscious moments. Medical examinations show nothing abnormal about my cardiovascular system, but I know that my heart is no longer entirely my own. Some part of Helen's physiological signature persisted after her death, continuing to influence my cardiac function in ways that conventional medicine can't detect or explain. The anchor effect, I've learned, sometimes creates connections that survive the death of one participant. Helen's heart stopped beating, but the rhythm we shared continues in my chest, a permanent reminder that some aspects of medical care extend beyond the boundaries of individual physiology. Sometimes, late at night when I'm alone, I can still hear Helen's voice saying thank you in perfect synchronization with the heartbeat that belongs to both of us. The Department of Radiology at Jefferson Medical College maintained one of the most comprehensive teaching archives in the region, containing over 40,000 digitized medical images collected during 3 decades of clinical practice. The collection served multiple educational purposes: case study materials for diagnostic training, research data for publication projects, and simulation datasets for testing new imaging analysis software. My assignment during the medical imaging Rotation involved cataloging and organizing historical CT scan files to improve database accessibility for future students. The work was methodical but valuable, providing exposure to hundreds of different pathological presentations while contributing to the department's educational infrastructure. Dr. Richard Hampton, the radiology department's academic coordinator, had established detailed protocols for the archival project. Accuracy is essential, he emphasized during my orientation. These images will be used for educational purposes for years to come. Any errors in classification or identification could mislead future students. The digital archival system was sophisticated, automatically generating metadata for each image based on acquisition parameters, patient demographics, and diagnostic findings. My responsibility was to verify the automated classifications and correct any errors that might have occurred during the digitization process. It was during my second week of archival work that I encountered the anomalous CT scan. The file was embedded within a batch of routine head and neck imaging studies from 2019, labeled with standard identifiers and technical parameters. But when I opened the image for review, the patient identification information displayed my own student ID number and personal details. According to the file metadata, the CT scan had been acquired on a date 5 years in the future. Using imaging protocols that hadn't been implemented yet at our institution, the study had been ordered by a radiologist whose name I didn't recognize, and the indication was listed as rule out skull fracture following trauma. The image itself showed a clear linear fracture extending across the left temporal bone, with associated soft tissue swelling consistent with recent head trauma. The fracture pattern was complex, involving both the temporal and parietal bones, and would likely have required surgical intervention if it were real. But the image was labeled with my name and identification numbers, suggesting that at some point 5 years in the future, I would sustain a serious head injury requiring emergency CT imaging. I checked the file properties more carefully, looking for evidence of data corruption or mislabeling that might explain the impossible future date. The technical parameters were consistent with current imaging equipment, and the image quality showed no signs of digital manipulation or corruption. "Dr. Hampton?" I called out, hoping he could provide clarification about the anomalous file. He approached my workstation and examined the image over my shoulder. "Interesting case," he said, studying the fracture pattern with professional interest. "Classic temporal bone fracture with extension into the parietal region. Good example for teaching trauma imaging. But the patient identification," I said, pointing to my name and student ID displayed in the image header. Dr. Hampton looked puzzled. "What about it?" I showed him the metadata displaying my personal information and the future date. Dr. Hampton examined the file properties on his screen, frowning as he scrolled through the technical details. "This is listed as part of our simulation dataset," he said after several minutes of investigation. "We use anonymized images with fictional patient identifiers for educational purposes. The system probably assigned random ID numbers that happened to match yours." The explanation seemed reasonable, though the specificity of the match, including my middle initial and the exact format of my student identification, was remarkably coincidental. "Should I reclassify it?" I asked. "No need," Dr. Hampton said. "It's properly categorized as simulation data. Just continue with your regular archival work." But the image remained in my mind throughout the day. The fracture pattern was severe enough to suggest significant trauma, a motor vehicle accident, sports injury, or serious fall. The associated soft tissue damage indicated the injury had occurred recently, probably within hours of the CT acquisition. That evening, as I left the medical school building, I paid closer attention to the staircase leading from the radiology department to the main lobby. The stairs were standard institutional construction, concrete with metal railings, adequate lighting, non-slip surface treatment. Nothing obviously hazardous, but like any staircase, potentially dangerous if navigated carelessly. The thought occurred to me that if I were going to sustain a serious head injury at the medical school, the stairs would be a likely location for such an accident. Over the following days, I found myself being unusually careful around staircases throughout the hospital and medical school. I used handrails consistently, avoided carrying items that might obstruct my vision, and maintained awareness of my footing during transitions between floors. The precautionary behavior felt rational given what I'd seen in the CT image, even though I understood intellectually that simulation Data couldn't predict actual future events. It was during my final week of radiology rotation that the accident occurred. Was leaving the medical school building after an evening study session, carrying several textbooks and a laptop bag that partially obscured my peripheral vision. The staircase lighting had been reduced to energy-saving levels after normal business hours, creating shadows that made depth perception more challenging. Approximately halfway down the staircase, my foot missed the edge of a step. The fall happened exactly as I'd imagined it might, based on studying the CT image for weeks. I tumbled forward, struck my head against the metal stair railing, and came to rest several steps below the point where I'd lost my footing. The impact site was precisely where the CT scan had shown fracture damage, the left temporal region, with force patterns that matched the imaging findings I'd been studying. Emergency medical services transported me to the hospital's trauma center, where Dr. Rebecca Chen ordered an immediate CT scan to assess for skull fracture. The imaging was performed using the same protocols and equipment that had generated the simulation data set I'd been cataloging. When Dr. Chen showed me the results, the fracture pattern matched the archived image exactly. Same location, same configuration, same extent of associated soft tissue damage. The correspondence was perfect down to minor details that would be impossible to predict or coincidentally replicate. "Looks like you'll need surgical consultation," Dr. Chen said, studying the images with concern. "This is a complex fracture pattern that will require careful monitoring." The surgery was successful and my recovery proceeded without complications. But when I returned to the radiology department several weeks later to complete my rotation requirements, I discovered that the original simulation file had been updated. The future date had been changed to reflect the actual date of my accident. The radiologist's name had been updated to Dr. Chen's credentials. The study indication now read, "Confirmed skull fracture following fall trauma," instead of the previous rule-out designation. According to the system logs, the file modifications had been made automatically, based on matching patient identification criteria and imaging findings. The database had apparently recognized the correspondence between the simulation data and actual clinical event, updating the records to reflect confirmed rather than hypothetical medical information. Since then, I've been more careful about my interaction with medical imaging databases. Sometimes the files seem to contain information about futures that haven't occurred yet, possibilities that exist in digital form before they manifest in physical reality. The radiology archive, I've learned, sometimes functions as more than just a collection of historical medical images. It tracks potential diagnoses alongside confirmed ones, documenting not just what has happened to patients, but what might happen to people who spend too much time studying medical pathology. Some educational databases, it seems, are more interactive than their technical specifications suggest. Neurological examination techniques formed a critical component of our third-year clinical skills curriculum at Riverside Medical College. Dr. Michael Torres, our neurology instructor, emphasized the importance of systematic assessment protocols that could detect subtle abnormalities often missed during routine physical examinations. The coursework required extensive practice with diagnostic procedures, reflex testing, cranial nerve evaluation, sensory pathway assessment, and cognitive function screening. Neurology is detective work, Dr. Torres explained during our introductory lecture. The human nervous system provides detailed information about pathological processes, but only if you know how to ask the right questions and interpret the responses correctly. The practical component of the course involved paired exercises, where students practiced examination techniques on each other under faculty supervision. The approach provided hands-on experience with normal neurological responses, while developing the technical skills necessary for clinical practice. My practice partner was Jennifer Walsh, a classmate whose academic performance and clinical aptitude had earned consistent recognition throughout our medical school curriculum. Jennifer approached the neurological examination exercises with the same methodical precision that characterized all her coursework, making her an ideal partner for learning complex diagnostic procedures. Our first few practice sessions proceeded normally. We worked through the standard neurological assessment sequence: mental status evaluation, cranial nerve testing, motor function assessment, sensory pathway examination, and reflex analysis. Jennifer's responses to all diagnostic tests fell within normal parameters, providing excellent examples of healthy neurological function. It was during our fourth practice session that I noticed the pupillary response abnormality. The pupillary light reflex test is one of the most basic neurological assessments, involving observation of pupil constriction when bright light is directed into the eye. Normal pupils constrict promptly and symmetrically when exposed to light stimulation, then return to their baseline size when the light source is removed. Jennifer's pupils didn't respond to light at all. When I directed the pen light toward her right eye, her pupil remained fixed at its baseline diameter, showing no constriction response. The same lack of response occurred with left eye testing, and cross-testing produced identical results. Her pupils appeared healthy in all other respects. Appropriate size, round configuration, no obvious structural abnormalities. Did you notice anything unusual? I asked, hoping Jennifer had observed the same abnormality. Everything felt normal to me, she replied. Did you detect any problems? I repeated the pupillary testing sequence, using different light intensities and approach angles to ensure accurate assessment. The results remained consistent. Complete absence of pupillary light reflex in both eyes. According to our neurology textbooks, this presentation suggested serious brainstem pathology, possible optic nerve damage, or other neurological conditions requiring immediate medical evaluation. Yet Jennifer showed no other signs of neurological dysfunction. Her vision appeared normal, her coordination was excellent, and her cognitive function was clearly unimpaired. We should probably ask Dr. Torres to take a look, I suggested. Jennifer seemed unconcerned. If you think it's necessary, she said. But I feel completely fine. Dr. Torres examined Jennifer's pupillary responses with considerably more sophisticated equipment than our student pen light. He used graduated light intensities, different wavelengths, and precise measurement tools to assess pupil size and reactivity. Interesting presentation, he concluded after several minutes of testing. Complete bilateral pupillary areflexia, but no other neurological abnormalities. Have you experienced any head trauma recently? Any changes in vision or cognitive function? Jennifer answered negatively to all his questions. Her medical history was unremarkable, with no previous neurological problems or relevant medication use. We should schedule you for ophthalmologic consultation, Dr. Torres decided. This degree of pupillary dysfunction warrants thorough evaluation, even in the absence of other symptoms. But when Jennifer returned the following week, she reported that the ophthalmology appointment had been canceled. They said there was no record of the referral. She explained. When I tried to reschedule, the receptionist couldn't find any documentation of the consultation request. Dr. Torres seemed puzzled by the administrative confusion, but Jennifer's apparent good health and normal function in all other areas made the pupillary abnormality seem less urgent. We'll continue monitoring the situation, he decided. Let me know immediately if you develop any other neurological symptoms. Over the following days, I noticed additional changes in Jennifer's behavior and presentation, though none of them seemed to concern her directly. She stopped blinking entirely. The absence of spontaneous blinking was subtle at first, something I might not have noticed if I hadn't been paying closer attention to her neurological status. But during our continued practice sessions, I realized that Jennifer's blink rate had decreased to 0. Her eyes remained open continuously, without the regular moisture distribution that normal blinking provides. Don't your eyes feel dry? I asked during one of our study sessions. Jennifer touched her eyes experimentally. Not particularly, she said. Should they? The lack of blinking should have caused significant discomfort and potential corneal damage. Yet Jennifer's eyes appeared healthy and properly lubricated. She showed no signs of the irritation or visual problems that would typically result from absent blink reflexes. During our final neurological examination practice session, Dr. Torres made a notation about Jennifer's condition in his teaching records. Interesting case study, he told me privately after class. Complete absence of several brainstem reflexes, but no apparent functional impairment. We'll want to follow her progress and document the presentation for educational purposes. The next day, Jennifer was absent from our regular classes. When I inquired about her whereabouts, Dr. Torres seemed surprised by my question. Jennifer? She's been excused from the neurology rotation. Her condition requires specialized evaluation. What condition? I asked. Dr. Torres consulted his records, looking puzzled as he reviewed his notes. According to my documentation, she's been transferred to the donor cadaver program. Apparently, her neurological status meets the criteria for brain death determination. The statement was impossible. I had been speaking with Jennifer the previous afternoon. She had been alert, conversational, academically engaged. Her cognitive function was clearly normal despite the pupillary and blinking abnormalities. That can't be right, I protested. I was just talking to her yesterday. Dr. Torres showed me his teaching records. Jennifer's name appeared in a section I hadn't noticed before. A list of students who had been transferred from active enrollment to the donor program based on medical criteria. The transfer date was listed as 3 weeks earlier, during our first practice session when I'd noticed the pupillary abnormalities. The documentation shows she's been clinically brain dead for 3 weeks, Dr. Torres said, examining the records with obvious confusion. But I have clear memories of her participating in class discussions during that entire period. I checked with the medical school registrar's office to verify Jennifer's enrollment status. According to their records, she had been withdrawn from all courses and transferred to the anatomical donation program, following brain death certification by the neurology department. Yet Jennifer's desk in our shared study room still contained her textbooks and personal items, arranged exactly as she had left them during our most recent study session. Her handwriting appeared in group project materials we had completed together over the past several days. That evening, I went to the gross anatomy laboratory to confirm whether Jennifer had actually been transferred to the donor program. I found her in dissection bay 7, properly prepared and positioned for educational use. The body was unmistakably Jennifer's, though the preservation process had altered her appearance in subtle ways that made definitive identification challenging. But when I approached the dissection table, Jennifer opened her eyes and looked directly at me. "The reflexes are gone," she said in the same conversational tone she'd used during our practice sessions. "But the awareness remains. It's an interesting distinction that the textbooks don't adequately explain." Her eyes still didn't respond to light stimulation, and she still wasn't blinking. But she was clearly conscious, alert, and capable of complex communication. "How is this possible?" I asked. "Brain death criteria are more flexible than most people realize," Jennifer replied. "Consciousness can persist even when the measurable reflexes have ceased. I'm learning things about neurology that aren't covered in our coursework. Since that conversation, I've been more careful about volunteering for neurological examination practice. The human nervous system, I've learned, sometimes operates according to principles that extend beyond conventional medical understanding." Jennifer continues to participate in the donor program while maintaining awareness that challenges our textbook definitions of brain death. The neurological examination techniques we practiced together revealed abnormalities that were real, but not necessarily incompatible with a form of consciousness that medical science hasn't adequately categorized. Some neurological conditions, it seems, exist in liminal spaces between life and death that our diagnostic criteria aren't designed to recognize. Overnight laboratory duties at University Medical Center offered fourth-year medical students valuable exposure to clinical pathology procedures while earning additional credit toward graduation requirements. The pathology department processed thousands of specimens daily: blood samples, tissue biopsies, microbiological cultures, and cytological preparations that supported diagnostic decisions throughout the hospital system. Dr. Angela Rodriguez, the pathology department's night supervisor, had established protocols that allowed medical students to assist with routine laboratory procedures under appropriate supervision. The work involved specimen processing, slide preparation, preliminary analysis, and quality control verification, technical skills that would prove valuable regardless of whatever medical specialty we eventually chose. Laboratory medicine is the foundation of modern healthcare, Dr. Rodriguez explained during my orientation to the Nightshift procedures. Approximately 70% of diagnostic decisions rely on laboratory data. Understanding how that data is generated makes you a better physician. The overnight shift began at 11 p.m. and concluded at 7 a.m., coinciding with the hospital's quietest operational period while ensuring continuity of essential laboratory services. During peak hours, the lab processed emergency specimens, maintained ongoing cultures, and prepared materials for the next day's diagnostic procedures. My first several nights of laboratory duty proceeded according to standard protocols. I assisted with specimen accessioning, prepared microscopic slides, and conducted basic analytical procedures under Dr. Rodriguez's direct supervision. The work was methodical and educational, providing insight into the technical processes that generated the laboratory results. I'd been interpreting during clinical rotations. It was during my third week of overnight duties that I began noticing irregularities in the specimen labeling system. The laboratory's computerized tracking system automatically generated identification labels for each specimen based on patient information and test requests submitted by clinical departments. The labels included patient name, medical record number, specimen type, requested analyses, and collection timestamps. Information that ensured proper handling and accurate result reporting. Around 3 a.m., during the night shift's typically quiet period, I observed the labels beginning to rearrange themselves. Not dramatically. The changes were subtle enough that I initially attributed them to fatigue or visual distortion from prolonged concentration on detailed work. But as I continued processing specimens, the pattern became unmistakable. Letters within patient names would shift position, creating different combinations while maintaining the same general appearance. Medical record numbers would change by single digits, altering patient identification in ways that might not be immediately detected. Collection timestamps would adjust by minutes or hours, potentially affecting the validity of time-sensitive analyses. The changes occurred gradually over the course of each night shift, and they followed a consistent pattern. The labels were becoming alphabetically organized, regardless of their original sequence or the actual specimen processing order. By 4 a.m., all the specimens I had processed were labeled with names beginning with the letter A. By 5 a.m., the names had progressed to B and continued through the alphabet as the night proceeded. Dr. Rodriguez, I called out during one of these episodes, hoping she could explain the automated labeling reorganization. She approached my workstation and examined the specimens I had processed. According to her observation, the labels displayed their original patient information without any alphabetical reorganization. "Everything appears normal," she said, reviewing the specimen tracking logs on the computer system. "Are you experiencing eye strain?" Night shift work can be visually demanding. I looked again at the labels that had been systematically reorganizing themselves. From my perspective, they clearly showed alphabetical arrangement with names that didn't match the original patient identifications. But Dr. Rodriguez saw only the standard specimen labels that corresponded to the computerized tracking records. Over the following nights, the alphabetical reorganization became more pronounced. By my fourth week of overnight laboratory duties, all specimens processed during my shift would eventually display names beginning with my own initials. Regardless of their original patient identification, the pattern progressed beyond simple alphabetical arrangement. The names on the labels began showing increasing similarity to my own name, subtle variations in spelling, different middle initials, similar phonetic combinations. By the end of each night shift, most specimens were labeled with versions of my name that differed by only 1 or 2 letters. More disturbing was the content of the specimens themselves. When I examined the blood samples under microscopic analysis, the cellular characteristics were becoming increasingly similar across different patients. Red blood cell morphology, white cell distributions, platelet counts. All the specimens were converging toward identical hematological profiles. The tissue biopsy samples showed similar convergence. Regardless of their original source, skin, liver, kidney, lung, the microscopic architecture was becoming uniform, displaying cellular characteristics that matched my own tissue type based on previous medical examinations I had undergone. Even the microbiological cultures were showing identical organism growth patterns, developing bacterial colonies that matched the normal flora I would expect to find in my own specimen samples. "Fascinating uniformity," Dr. Rodriguez commented during one of her quality control reviews. "These specimens show remarkably consistent characteristics for samples from different patients." Good technique on your part, but I hadn't altered any of the processing procedures. The convergence toward uniform characteristics was occurring independently of my technical work, as if the specimens were actively transforming themselves during the overnight processing period. During my 5th week of laboratory duties, I began finding specimens that hadn't been submitted by clinical departments. New samples would appear in the processing queue without corresponding requisition forms or computer tracking entries. The labels identified them as originating from my own patient care activities, though I hadn't collected any specimens from patients during my current rotation. The unauthorized specimens included blood samples, tissue biopsies, and microbiological cultures that were all labeled with my name and student identification number. According to the tracking system, I had somehow submitted these samples for analysis of my own biological materials. When I examined these samples under microscopic analysis, they showed pathological changes that weren't present in my normal health status. Abnormal cell morphology, tissue architecture disruption, bacterial infections that would require immediate medical treatment if they were actually present in my body. Yet I felt completely healthy, with no symptoms that would suggest the serious medical conditions reflected in the specimen analyses. These samples suggest significant pathology, Dr. Rodriguez said. Reviewing the microscopic findings, have you been experiencing any health problems recently? I explained that the specimens had appeared without my knowledge or submission, and that I had no symptoms corresponding to the analytical findings. Dr. Rodriguez seemed puzzled. The computer system shows you submitted these samples for routine health screening, she said, consulting the electronic tracking records. The requisition forms are properly completed with your electronic signature. She showed me the computer screen displaying specimen submission forms that bore my name and electronic authorization. The forms requested comprehensive pathological analysis, including blood chemistry, tissue biopsy interpretation, and microbiological identification. Had no memory of submitting these requests or providing the biological samples for analysis. The results indicate several serious medical conditions that require immediate clinical attention, Dr. Rodriguez continued. We'll need to schedule you for follow-up evaluation with appropriate specialists. But when I attempted to schedule the recommended medical consultations, the hospital's appointment system showed no available openings. Every attempt to arrange follow-up care resulted in scheduling conflicts, unavailable physicians, or administrative errors that prevented appointment confirmation. The pathological findings in my specimen analyses continued to accumulate. Each night shift produced new samples labeled with my identification, showing progressively more severe abnormalities that would be life-threatening if they represented actual medical conditions. Yet my physical health remained normal, with no symptoms or functional limitations that corresponded to the laboratory evidence of serious disease. During my final week of overnight laboratory duties, I realized that all the specimens processed during my shifts were now labeled with my name and identification information. Every blood sample, tissue biopsy, and microbiological culture showed my personal data, regardless of their actual source patients. The laboratory was processing hundreds of specimens each night, all apparently originating from my own biological systems. The analytical results suggested that my body was simultaneously exhibiting every pathological condition represented in the hospital's patient population. Remarkable case presentation, Dr. Rodriguez said, reviewing the comprehensive pathological data that had accumulated over my rotation. You're demonstrating virtually every disease process we encounter in clinical practice. This will make excellent educational material for future students. According to the laboratory's electronic records, I had become a teaching case, a single patient whose biological samples illustrated the full spectrum of human pathology. The specimens labeled with my name now comprised a comprehensive collection of disease presentations that would be used for educational purposes throughout the medical school curriculum. When I checked my own medical record in the hospital system, it showed multiple diagnoses corresponding to all the pathological findings detected in the specimen analyses. According to the official documentation, I was simultaneously suffering from dozens of serious medical conditions that would be mutually exclusive in normal clinical presentations. Yet I remained healthy, functional, and asymptomatic. The laboratory work, I realized, had transformed me into a living pathology textbook, someone whose biological samples could illustrate any disease process required for educational purposes, while my actual physical condition remained unaffected by the documented pathology. Since completing that rotation, I've avoided volunteer laboratory work and routine medical screening procedures. But sometimes when I'm studying pathology materials or examining patient specimens during clinical rotations, I recognize cellular characteristics that match the microscopic images from my own overnight laboratory analyses. Medical education, it seems, sometimes requires students to become the diseases they're learning to diagnose. The boundary between studying pathology and embodying it is more permeable than anyone acknowledges during orientation sessions. Some learning experiences, I've discovered, leave permanent traces in both medical records and biological reality. The pager system at Metropolitan General Hospital represented one of the last vestiges of analog communication technology in an increasingly digital medical environment. Despite the widespread adoption of smartphones and secure messaging applications, many healthcare facilities maintained pager networks for emergency communications that required absolute reliability and hospital-wide coverage. As a fourth-year medical student rotating through various clinical services, I was assigned a standard-issue pager for receiving urgent communications from supervising physicians, nursing staff, and emergency departments. The device was simple, capable of receiving numeric messages, basic text communications, and priority alerts that identified the urgency level of each message. During my emergency medicine rotation, the pager served as a critical link to the attending physicians who supervised student activities. Dr. Margaret Foster, the emergency department's director of medical education, emphasized the importance of prompt response to pager communications, particularly during busy shifts when rapid decision-making could affect patient outcomes. "Your pager is your lifeline," Dr. Foster explained during orientation. "When it goes off, you respond immediately. In emergency medicine, delayed communication can be the difference between successful treatment and catastrophic outcomes." The ICU emergency department operated at a consistently high intensity level, processing trauma cases, cardiac emergencies, psychiatric crises, and acute medical conditions that required immediate intervention. The pager traffic was correspondingly heavy, with frequent messages coordinating patient care, requesting consultations, and alerting staff to changing clinical situations. It was during my second week of emergency medicine rotation that I received the anomalous message. The pager buzzed at 1:17 p.m. during a brief lull in emergency department activity. The message display showed a 4-word communication in the standard format used for emergency alerts. Code blue, room 414. Code blue indicated cardiac arrest or other life-threatening emergency requiring immediate response from all available medical personnel. The message format was standard, consistent with hundreds of similar alerts I had received during my clinical rotations. But Metropolitan General Hospital didn't have a room 414. The hospital's floor plan was familiar to me after 3 months of rotations in various departments. The 4th floor housed the intensive care unit, with rooms numbered 401 through 436. Room 414 would logically be located in the middle of the ICU corridor, but that space was occupied by a family consultation room that had never been assigned a patient care designation. I checked with the emergency department charge nurse to confirm the room number accuracy. Room 414. Nurse Patricia Williams looked puzzled. "There's no room 414 in the hospital. Are you sure that's what the message said?" I showed her the pager display, which clearly indicated code blue, room 414. The message timestamp and transmission codes were consistent with official hospital communications. "Must be a system error," she concluded. "Sometimes the pager network picks up messages from other hospitals in the area. I wouldn't worry about it." But the message continued to bother me throughout the afternoon. Emergency communication systems were designed with multiple redundancy safeguards to prevent exactly this type of error. The probability of receiving a misdirected code blue alert was extremely low, particularly one that specified a room number that didn't exist. During my dinner break, I decided to investigate the 4th floor ICU to confirm the room numbering system. The elevator opened onto the familiar corridor that I had traversed many times during previous rotations. Rooms 401 through 436 were clearly marked and properly numbered, with the family consultation area occupying the space where room 414 would logically be located. But as I walked through the corridor, I noticed a maintenance stairwell that I hadn't observed during previous visits to the 4th floor. The stairwell was tucked into an architectural recess near the elevator bank, marked with a simple sign reading, "Authorized personnel only." The door was unlocked, opening onto a narrow staircase that ascended to what appeared to be a fifth-floor level. Metropolitan General Hospital was a 4-story building. There was no fifth floor. I climbed the staircase out of curiosity, expecting to find rooftop access or mechanical equipment areas. Instead, the stairs terminated at a standard hospital corridor that appeared identical to the 4th-floor ICU, complete with patient rooms, nursing stations, and medical equipment. The room numbers in this impossible 5th-floor corridor began with 414. Room 414 was located exactly where it should be, based on the hospital's standard room numbering convention. The door was closed, but a standard patient room placard indicated current occupancy. Through the small window in the door, I could see medical equipment suggesting active patient care. I approached the room cautiously, uncertain whether I was experiencing some kind of hallucination or had discovered a section of the hospital that wasn't included in standard floor plans. As I reached for the door handle, I heard someone inside the room calling for help. The voice was clearly audible through the door, not the mechanical tone of an automated alert system, but a human voice expressing genuine distress. Someone was requesting immediate medical assistance for what sounded like a cardiac emergency. The voice was my own. I was hearing my own voice from inside room 414, calling for help with the same inflection and urgency I would use during an actual medical emergency. The voice was asking for immediate response to a code blue situation, using medical terminology and communication protocols that were second nature to me after months of clinical training. I tried the door handle, but the room was locked. Through the window, I could see medical equipment and what appeared to be a patient in the bed, but the angle didn't allow clear observation of the specific situation. The voice inside continued, calling for help, using my exact tone and speech patterns to request emergency intervention. The calls were becoming more urgent, suggesting that whatever medical crisis was occurring was deteriorating rapidly. I used my hospital identification card to access the room's electronic lock, but the system didn't recognize my credentials. According to the door's security display, room 414 required authorization levels that weren't associated with my student access privileges. As I stood outside the locked room, listening to my own voice calling for help that I couldn't provide, the pager in my pocket buzzed again. The new message was identical to the first, code blue, room 414. But this time the message was accompanied by additional text identifying the emergency's nature. Student unresponsive. Require immediate assistance. I looked around the corridor, expecting to see other medical personnel responding to the code blue alert. The hallway remained empty, with no indication that anyone else had received the emergency communication or was aware of the situation in room 414. My pager buzzed a third time. Please respond immediately. Time critical. The message appeared to be specifically directed to me, though the hospital's code blue system was designed for broadcast communication to all available personnel. I tried calling the hospital operator to report the emergency and request assistance accessing room 414. But when I dialed the standard internal number, the call connected to my own voice answering with professional medical identification. This is the student responding to room 414. What's your location? I hung up immediately, disturbed by the impossibility of calling myself through the hospital communication system. When I returned to the emergency department, Dr. Foster asked about my extended absence from the clinical area. I was responding to a code blue alert, I explained, showing her the pager messages. Dr. Foster examined my pager display, but the screen showed only routine communications from earlier in the day. The room 414 messages had disappeared completely. There haven't been any code blue alerts this shift, she said. Are you feeling all right? Sometimes the stress of emergency medicine rotation can cause auditory or visual hallucinations. I wanted to explain about the 5th floor corridor and the impossible room where my own voice was calling for help, but the explanation sounded delusional even to me. That evening I returned to the 4th floor to locate the maintenance stairwell I had used to access the upper corridor. But the stairwell door was gone, replaced by solid wall that appeared to have been part of the original hospital construction. Since that shift, my pager occasionally receives messages from room 414, always requesting immediate response to medical emergencies. But I've learned not to investigate these alerts, and I don't mention them to supervising physicians. Some emergency, Calls, I've realized, come from versions of ourselves that are trapped in impossible situations, calling for help that we can't provide because we're not equipped to rescue ourselves from circumstances that shouldn't exist. The hospital's communication systems sometimes carry messages from parallel situations where we're the patients rather than the medical providers, reminding us that the boundary between healing and needing healing is more fragile than we'd like to believe. The Department of Sleep Medicine at University Research Hospital conducted ongoing studies investigating the effects of sleep deprivation on cognitive performance, decision-making capacity, and physiological stress responses. As medical students, we were frequently invited to participate in research protocols that offered modest financial compensation while contributing to scientific understanding of phenomena that directly affected our professional training. Dr. Susan Mitchell, the department's principal investigator, had designed a comprehensive study examining how extended wakefulness affected diagnostic reasoning abilities in medical students. The research protocol involved controlled sleep deprivation periods followed by cognitive testing and physiological monitoring to establish correlations between fatigue levels and clinical decision-making. Accuracy. Medical training inherently involves sleep deprivation. Dr. Mitchell explained during the study orientation session. Understanding how fatigue affects diagnostic reasoning can help us develop better training protocols and patient safety measures. The study required participants to remain awake for 48 consecutive hours while performing standardized cognitive assessments at regular intervals. Physiological monitoring equipment tracked heart rate, blood pressure, brainwave patterns, and stress hormone levels throughout the deprivation period. The controlled environment ensured participant safety while generating scientifically valid data about sleep deprivation effects. I volunteered for the study during my 4th year, motivated partly by the research stipend and partly by professional interest in understanding how fatigue affected my own clinical performance during extended hospital shifts. The sleep laboratory occupied a dedicated wing of the hospital's research facility, equipped with comfortable monitoring rooms, sophisticated recording equipment, and observation stations where research staff could maintain continuous supervision of study participants. The environment was designed to prevent accidental sleep while providing appropriate safety monitoring throughout the extended wakefulness period. My assigned monitoring room contained a hospital bed equipped with sensors for physiological data collection, a desk with computer access for cognitive testing, and basic amenities for extended occupancy. The setup was similar to hospital call rooms, but with additional electronic monitoring equipment and no expectation of sleep opportunity. The first 24 hours of sleep deprivation proceeded according to the established research protocol. I completed cognitive assessments every 4 hours, maintained detailed logs of subjective fatigue levels, and submitted to regular physiological monitoring by the research staff. The testing battery included diagnostic reasoning scenarios, memory recall exercises, and reaction time measurements designed to quantify the effects of progressive sleep loss. Dr. Mitchell and her research team maintained professional oversight throughout the process, ensuring participant safety while collecting data that would contribute to medical understanding of sleep deprivation effects. The monitoring was unobtrusive but comprehensive, tracking both subjective reports and objective physiological changes. It was during the second 24-hour period that I began experiencing irregularities in the data collection process. The cognitive testing computer began displaying assessment results before I had completed the actual tests. When I started each diagnostic reasoning scenario, the system would show detailed response data indicating that I had already finished the exercise with specific accuracy scores and completion times. According to the computer records, I was completing cognitive assessments with remarkable consistency despite increasing sleep deprivation. The diagnostic accuracy scores remained stable throughout the extended wakefulness period, showing none of the performance degradation that characterized typical sleep deprivation research findings. Interesting results, Dr. Mitchell commented during one of her monitoring rounds. You're showing unusual resilience to cognitive impairment despite significant sleep loss. Have you had previous experience with extended wakefulness? I explained that medical school had provided considerable exposure to sleep-deprived conditions, but nothing as systematic as the current research protocol. Your physiological monitoring data is also unusual, she continued, reviewing the electronic records on her tablet. Heart rate variability, stress hormone levels, brainwave patterns, all showing remarkable stability despite 40-hour sleep deprivation. But when I examined the monitoring displays in my room, the physiological data appeared normal for someone experiencing significant sleep loss. Elevated heart rate, irregular brainwave patterns, stress responses consistent with extended wakefulness. The objective measurements matched my subjective experience of increasing fatigue and cognitive impairment. Dr. Mitchell seemed to be observing different data than what appeared on the monitoring equipment in my room. During the final 8 hours of the study, I began questioning whether I was actually sleep-deprived or had somehow been sleeping without awareness. The 48-hour timeline felt accurate based on my subjective experience and the regular cognitive assessments I had been completing. But the research data suggested that I had been receiving adequate sleep throughout the supposed deprivation period. When I mentioned this discrepancy to Dr. Mitchell, she showed me the comprehensive sleep monitoring records from the past 2 days. According to our polysomnographic data, you've been achieving normal sleep architecture throughout the study period, she said, displaying waveform patterns that indicated regular sleep cycles, REM sleep, deep sleep phases, normal duration, and quality. The sleep data was time-stamped and correlated with video monitoring that should have captured any sleep episodes during the study period. But I had clear memories of remaining awake continuously, struggling with increasing fatigue, and experiencing the cognitive effects of extended wakefulness. This is very unusual, Dr. Mitchell admitted. Your subjective reports indicate complete sleep deprivation, but our objective monitoring shows normal sleep patterns. It's as if you were simultaneously awake and asleep for the entire 48-hour period. She consulted with her research team to determine whether equipment malfunction might explain the contradictory data, but multiple independent monitoring systems had recorded identical results, evidence of normal sleep architecture, during a period when I was convinced I had remained continuously awake. When I asked to review the video monitoring footage, Dr. Mitchell showed me recordings from my assigned room throughout the study period. The video showed me sleeping peacefully for approximately 8 hours each night, maintaining normal sleep posture and breathing patterns. But it also showed me remaining awake and active during the same time periods, completing cognitive assessments and interacting with research staff. The recording somehow captured 2 simultaneous versions of my participation in the study, one sleeping normally, one experiencing complete sleep deprivation. The video system appears to have malfunctioned, Dr. Mitchell concluded. We're getting overlapping footage that doesn't correspond to the actual study conditions. But when she showed me the cognitive assessment records, I found 3 complete sets of test results spanning the 48-hour period. One set showed the progressive cognitive decline expected during sleep deprivation, decreasing accuracy, slower reaction times, impaired diagnostic reasoning as fatigue accumulated. The second set showed stable performance throughout the study period, consistent with adequate sleep and normal cognitive function. The third set showed enhanced performance beyond baseline measurements, improved accuracy, faster response times, better diagnostic reasoning than I had achieved during well-rested conditions. All 3 data sets were attributed to my participation and signed with my electronic authorization, but they represented mutually exclusive experiences of the same research protocol. We seem to have documented 3 different versions of your study participation, Dr. Mitchell said, examining the multiple data sets with obvious confusion. Each set is complete and internally consistent, but they can't all represent the same 48-hour period. When I was discharged from the sleep laboratory, I discovered that the research compensation had been processed 3 times. Payment for 3 separate study completions using my identification and banking information. The final research report, when it was published 6 months later, included my case as an example of unusual individual variation in sleep deprivation response. According to the published data, I had simultaneously demonstrated typical sleep deprivation effects, resilience to sleep loss, and enhanced performance under fatigue conditions. The researchers concluded that some individuals might experience multiple physiological responses to sleep deprivation simultaneously, though the mechanisms underlying this phenomenon weren't clearly understood. Since completing that study, My relationship with sleep has become more complicated. Sometimes I'm aware of sleeping while also remaining awake to complete necessary tasks. Medical school demands seem to require a level of consciousness that extends beyond normal physiological limitations. I've developed the ability to attend lectures, complete clinical duties, and study for examinations while simultaneously getting adequate sleep, though I'm not entirely certain how this works or whether other people can observe both states simultaneously. Sleep deprivation research, I've learned, sometimes reveals capabilities that medical students develop out of necessity, ways of existing in multiple states of consciousness that allow us to meet the impossible demands of medical education while maintaining the physiological requirements for survival. Some studies, it seems, don't just observe existing phenomena, but create new ways of being that persist beyond the research environment. The final case presentation represented the culminating requirement for graduation from Jefferson Medical College, a comprehensive analysis of a complex patient case that demonstrated integration of clinical knowledge, diagnostic reasoning, and treatment planning skills acquired throughout 4 years of medical education. Each student selected a case from their clinical rotations that showcased their understanding of medical practice and their readiness for residency training. Dr. Eleanor Hartwell, the academic director responsible for final presentations, emphasized the importance of this requirement as both educational exercise and professional milestone. Your case presentation should reflect your growth as a medical student and your preparation for independent clinical practice, she explained during the preparatory seminars. Choose a case that challenged you, taught you something significant, and demonstrates your clinical reasoning abilities. The presentation format required detailed analysis of patient history, physical examination findings, diagnostic workup, treatment decisions, and clinical outcomes. Students had 6 weeks to prepare comprehensive presentations that would be evaluated by faculty panels representing multiple medical specialties. I began my case selection process by reviewing patient encounters from my various clinical rotations, looking for cases that met Dr. Hartwell's criteria for educational value and complexity. After considerable deliberation, I chose a case from my internal medicine rotation, a middle-aged man with unusual cardiac symptoms that had required extensive diagnostic evaluation and multidisciplinary treatment planning. The patient, whom I'll call Robert Henderson for confidentiality purposes, had presented with chest pain, shortness of breath, and exercise intolerance that didn't fit typical patterns for common cardiac conditions. The diagnostic workup had included electrocardiograms, echocardiography, cardiac catheterization, and specialized testing that revealed a rare congenital heart defect that had remained undiagnosed until his 5th decade of life. The case was medically interesting, educationally valuable, and had resulted in successful treatment that significantly improved the patient's quality of life. It seemed ideal for demonstrating my understanding of cardiovascular medicine and my ability to participate in complex diagnostic reasoning. As I began preparing the presentation materials, I discovered unusual parallels between Robert Henderson's medical history and my own personal background. The patient had been born in the same city where I grew up, had attended the same high school I graduated from, and had experienced several childhood illnesses that matched my own medical history. These coincidences were remarkable, but not impossible. People from similar geographic backgrounds often share common environmental exposures and healthcare experiences. More disturbing were the similarities in family medical history. Robert Henderson's presentation described genetic risk factors, inherited conditions, and familial disease patterns that were identical to my own family's medical background. Not similar, identical, down to specific details about grandparents' causes of death and siblings' childhood health problems that wouldn't be recorded in typical medical histories. When I reviewed the physical examination findings, the parallels became even more precise. Robert Henderson's height, weight, and general physical characteristics matched my own measurements exactly. Distinguishing marks, scars, and anatomical variations described in his medical record corresponded to features of my own body that I had observed during medical school physical examination training. I checked the medical record more carefully, looking for documentation errors that might explain the impossible correspondences. But the record was comprehensive and internally consistent, containing detailed information that couldn't have been fabricated or accidentally duplicated from another patient's file. Most concerning was the photographic documentation included in Robert Henderson's case file. Medical records sometimes contain photographs for documentation purposes, skin lesions, surgical sites, diagnostic imaging results that support clinical decision-making. Robert Henderson's file contained standard medical photography, but when I examined the images carefully, they showed my own face and body, not resemblances or similarities. The photographs were unmistakably of me, taken from angles and in clinical settings that I didn't remember participating in. The images showed medical conditions and physical findings that I hadn't experienced, documented in a professional clinical photography format that suggested they had been taken as part of routine medical care. Consulted with Dr. Hartwell about the unusual similarities between my chosen case and my own medical profile. Interesting coincidences, she said, reviewing the case materials I had prepared. Sometimes we're drawn to cases that resonate with our own experiences or backgrounds. That's not necessarily problematic, as long as your analysis maintains appropriate clinical objectivity. But when Dr. Hartwell examined Robert Henderson's medical record, she seemed to see different information than what appeared in my copies of the same documents. This case shows excellent diagnostic complexity, she commented, reviewing materials that I perceived as containing my own medical information. The patient's presentation is quite unusual, not typical for someone with your demographic profile. According to Dr. Hartwell's observation, Robert Henderson was a 73-year-old African-American woman with diabetes and hypertension, a completely different patient than the middle-aged Caucasian man whose case I had been studying. I showed Dr. Hartwell the specific documents that contained my personal information and photographs, but she continued to see the elderly female patient's medical record. "Are you experiencing some kind of stress-related confusion?" she asked with concern. "The final presentation requirement can be psychologically demanding. Perhaps you should consider selecting a different case." But when I attempted to access other patient records from my clinical rotations, I found that all the cases had been transformed. Every patient file I had worked with during medical school now contained my personal information, my medical history, and photographs of my own body documenting conditions I had never experienced. According to the electronic medical record system, I had been the patient in every clinical encounter I had participated in as a medical student. The role reversal was complete and systematic, affecting hundreds of patient interactions spanning 4 years of clinical training. When I checked with classmates about their final presentation preparations, they reported no similar difficulties with patient record access or case selection. Their chosen cases remained stable and accessible, containing appropriate patient information that supported comprehensive analysis. Only my patient records had been transformed to reflect my own medical information. As the presentation deadline approached, I decided to proceed with Robert Henderson's case despite the impossible personal correspondences. I prepared the analysis according to standard requirements, treating the medical information as if it belonged to another patient rather than myself. During the actual presentation, I described Robert Henderson's case to the faculty evaluation panel with appropriate clinical objectivity. I discussed the diagnostic reasoning process, treatment decisions, and clinical outcomes as if I had been the medical student provider rather than the patient. The faculty panel received the presentation positively, asking thoughtful questions about diagnostic alternatives, treatment considerations, and lessons learned from the clinical experience. But when I reached the conclusion of my presentation, the final slide appeared automatically with content I hadn't prepared. The slide was titled Treatment Outcome and Prognosis and contained a single sentence. Subject accepted treatment. Prognosis unteachable. Dr. Hartwell and the evaluation panel seemed to find nothing unusual about this conclusion, nodding in agreement as if the statement represented a standard clinical assessment. "Excellent presentation," Dr. Hartwell said. "You've demonstrated sophisticated understanding of this complex case and your readiness for residency training." According to the evaluation scores, I had successfully completed the final presentation requirement and was approved for graduation from medical school. But the medical record system continued to show me as the patient in Robert Henderson's case, with ongoing treatment recommendations and follow-up requirements that extended beyond the presentation deadline. According to the treatment plan, I was scheduled for lifelong monitoring of the rare cardiac condition that had been the focus of my presentation. The prognosis section noted that while the medical condition was treatable, the underlying educational deficits were unteachable and would require permanent documentation in my medical record. Since graduation, I've maintained access to the medical record system. Though my status has changed from medical student to patient, my own medical file continues to expand with documentation from clinical encounters I don't remember participating in, treatments I haven't received, and consultations with specialists I've never met. The boundary between providing medical care and receiving it, I've learned, is more permeable than medical school curriculum suggests. Sometimes the education process transforms students in ways that extend beyond acquired knowledge and clinical skills. We study disease to understand healing, but sometimes the studying process makes us the subjects of our own clinical investigation. The final case presentation, it seems, sometimes becomes a diagnosis of our own condition rather than analysis of someone else's medical problem. Medical education, I now understand, occasionally produces graduates who have learned too much about the relationship between healing and suffering to function as purely objective healthcare providers. We become living case studies of conditions that medical science hasn't adequately categorized, professionally qualified but personally compromised by our understanding of how much we don't know. Some patients, it turns out, are more teachable than their doctors.